This
Okay.
conference will now be recorded.
Good day, everybody. A rather disaster has happened this morning, and I have lost my presentation, which I put the stations for this. I think I probably closed that without saving. I mean, I clicked save, but probably it wasn't saved. So that's a reason of a little bit late start as well. I have been trying to find out everywhere where that is gone. So I have lost that in summary. So what I'm now going to do is and for some weird reason, the last time the structure discussion presentation, the last one, I can't find that either. So I have just opened the recording of last one now. At least there will be 3-4 stations we can start with. And then we will continue with others adding up. So I need you guys to post structure discussion stations on WhatsApp. So I have opened WhatsApp on this laptop as well. So I can just see. So there was a station I added, a lady with ulcerative colitis, pregnancy with ulcerative colitis, and she is on infliximab. So if somebody can just post that on there, and then sickle cell disease, sickle cell anemia in the pregnancy, sickle cell disease in pregnancy. So can somebody please post that there so I can put that on the, then we can open on the screen from there. Oh dear. Okay, so no, this one. So this is absolutely not how you want to actually conclude your otherwise such beautifully run course. Last session and this disaster, I'm feeling really upset. Can somebody speak and confirm you guys can hear me? And I'm not just moaning on my own.
Yes, ma'am, we can hear you. It's okay, ma'am. We will go through the previous recording.
Yes, if you guys can hear me, at least express some sympathies. Right then.
Ma'am, can you hear us?
Yes,
I
yes,
can hear
we
you.
can hear
Yes.
you. Yeah.
Yes.
Ma'am,
So
it's
yes,
okay. We will go through the previous recording. It's okay, ma'am.
yeah, no, we'll take the slides only from there, and then yes, we will do the discussion, and then obviously we need to add more. So if you guys just please send me in November group or July group, wherever, you know, any other stations you want to discuss. So I'm going to start from here. Obviously, we want to have a idea about like how the structure, I mean, we have done most of structure discussions anyway, and you guys have the idea how to do them. But still just a couple more before we discuss some other important things. So anybody who has read about this condition and who can beautifully present this, please? Any volunteer?
Ma'am, should we take that order in which we were going?
That would be great if you have, yes, that's fine.
Yes, because last class we didn't use that, so we can use that one.
It's fine with me.
Okay.
So who is the one?
Lubna was the first one. Lubna was the first one. Lubna is here. Lubna. If not, Rabab. Rabab, are you there? No. Neelam.
Yes, I'm here.
Yeah, Neelam is there. Yeah. Neelam.
Ma'am, is it non-immune high drops or?
Yeah, you need to have a look to see what that is. That's what the task is, yeah? I can start in your 2 minutes now. Okay, you can start. Hello, Neelam, can you hear me?
Yes, yes, ma'am.
Okay, so you can start.
Okay, so hello, I'm Dr. Yeah, good afternoon. I'm Dr. Neelam, one of the candidate for this examination. I'm ready for the structural discussion. So, looking to these images of the ultrasonography, it is most probably hepatosplenomegaly with ascites and maybe some hydrops in the baby. So, to find out the diagnosis, I need to ask about the history of the patient. So I need to ask about her present pregnancy, regarding her age, her gestational age, what is her, how many weeks of pregnancy she is she having any problem in this pregnancy, and regarding her past any history of nausea, vomiting, or any fever in this pregnancy, like any history of viral fever or in this pregnancy. And then I need to ask about her previous pregnancies also. So about her obstetric history, how many pregnancies she had, and what was the course of pregnancy and delivery. And also any medical illness like any hemoglobinopathies on a thalassemia, alpha thalassemia, or sickle cell disease, or any viral infections, or if the patient is anemic. So I need to ask these things from the patient. And is any social history of alcohol or smoking, and any recreational drugs she is taking, like cocaine and all. And I need to ask also about the domestic violence, also about any surgery in the past, any medicine she is taking right now, and her blood group. Is she Rh negative? Is she has her antibody titer, Rh antibody titers have been done? Is she immune, or uh, her not immune to this Rh antibodies? And I need to know her BMI. So the pathophysiology of this condition may be there may be several reasons of hydrops in the baby. The most common was Rh incompatibility, that is, if the mother has become sensitive to Rh. Ma'am, am I going wrong? Is it?
No, it's fine. You're doing fine. So keep telling me, yeah.
Yeah,
And mostly your examiners will be like that. Okay, they will just be sitting quiet, silent, lost.
Okay, ma'am.
But if you're not
Okay.
quite right in your diagnosis and time, then obviously they will give you some hint or something. Yeah.
Okay. So the most the causes of hydrops may be hemolytic disease of the newborn, which may be because of Rh negative, or sometimes other blood groups may be incompatibility of the other blood groups may also cause hemolytic disease of the newborn. It may be because of severe anemia in the mother, and also maybe infections at the in the mother, like cytomegalovirus or toxoplasmosis, or even parvovirus is the commonest. If so, I need to ask her occupation also, like patients who are in teaching job, or whom they are in contact with small children, they may are more at risk of getting this parvovirus infection. Is the patient having any heart or lung disease? Any chromosomal abnormalities may be there in the baby. I need to see whether any other birth defects are also seen in the sonography report. And also sometimes rare liver diseases, and also some kind of even the BDRL, that is syphilis, can cause also this hydrops. So these are the various conditions which may lead to hydrops, and the pathophysiology is usually of this condition is that usually the virus or the underlying pathology, like even if it is Rh incompatibility, then the baby becomes anemic, and then it leads to ascites and hydrothorax. Because of anemia, the cardiac failure occurs, and there is fluid overload, and this leads to fluid in the third space, as well as ascites, hydrothorax, and as fluid in the soft tissues also. And this leads to the appearance of hydrops in the sonography. And the common pathophysiology of all these conditions is fetal anemia. So be it be parvovirus, be it be CMV, be it be herpes simplex, or even this syphilis virus, or sometimes sickle cell, or mother is anemic because of any reasons. These all conditions can lead to fetal anemia, and this can lead to the picture of fetal hydrops. So we need to find out by doing various tests to see the reason of, like, we need to find the blood group and rare blood group also, whether she is immune to it, or she has become sensitized to it. And also we have to do viral screening, all IgG, IgM of including her booking bloods. We need to see the CMV, we need to see the herpes virus, we need to see the toxoplasma, adenovirus, and Treponema pallidum test also we need to repeat. So these are the investigations we are going to do. And then we need to refer the patient to the fetal medicine center for tertiary center to, ma'am, can I see the questions? Yeah. So we need to refer the patient to the fetal medicine center. The diagnosis further confirm. We need to do all these tests to reach to a confirmatory diagnosis, and then we need to send the patient, refer the patient to the fetal medicine center, where the cause, according to the cause of the hydrops fetalis, treatment would be started, and this needs to be done by doing the middle cerebral artery PCV, and also we need to follow, and maybe if required they may need to do intrauterine blood transfusion to the baby, depending on the how much anemic the baby is and what gestational age the baby is, and accordingly the prognosis will be given to the parents. And if it is, and depending on the cause, the treatment will be given. So parvovirus, usually if it is given intrauterine blood transfusion, and we follow the pregnancy, then the once the baby anemia becomes cured, then the baby goes well, and the prognosis is good. And if it is syphilis, then we need to give the after ruling out any anaphylaxis or any allergy to penicillin, we need to give the treatment. And if CMV is there, we need to tell the parents about the prognosis. It may be associated with other malformations, congenital malformations also. So we need to rule out the cause of the hydrops fetalis. It may be because of sometimes alpha thalassemia also. So according to the cause, the treatment would be decided, and the treatment would be planned at the tertiary fetal medicine unit.
Okay, yeah, that's fine. To stop here. Yeah, that's nice. That was done in a nicer manner. So you need to, yes. So when the structured discussion starts, it's a clinical discussion. So all the you must use the clinical terminology. Okay. So yes, so usually you can be given some ultrasound scan report, or I mean, there can be a scenario given over there as well, from where you have to establish your diagnosis, right? So the way you start is, I have this scan report and I can see, then you need to, that terminology units, I can see the ascites, I can see hydrothorax, and, then they, that, and that goes towards, you will see that goes towards hydros fetalis. And then you can start your discussion, which is a little bit. So then there will be some questions sometime, what you can see and tell your diagnosis. So you start from your diagnosis, and then just like these should be very simple. There will be one station at least where there will be quite very simple, clear guideline, either NICE guideline, R3G or TOG article, and you just have to basically tell all their guideline. In different, so if the examiner is specifically asking some questions, you can answer them. Otherwise, just simply start, just like medical school style, like what it is, what can be the differential diagnosis, what possible can be the pathology. So you start, this is hydros fetalis, and there are two types of hydrofetalis, immune and non-immune hydrofetalis. And then you will go into the the details, like tell the reasons and the causes of which one is most common. And then you will say, for example, you can start from immune hydrofetalis, and you can go for the causes of that to say, that's most commonly occurs because of RH incompatibility, where RH negative mother, she can develop antibodies against the RH positive fetus. And then in the next pregnancy, or even during that pregnancy as well, there can be hemolytic disease of the newborn. And then that can result. So then you need to tell what exactly happens after that. Yeah. So because of that, obviously the fetus can have cardiac failure, or and that can result into failure of the fetus to arrange the body fluids, and that results in extravasation of all that fluid into extra cellular spaces and also into the cavities. So that will be that. Then you need to tell about the causes of the non-immune hydrophytalis, which you need to. So that basically is most common cause now, since the Rh antibody, anti-Rh antibody medication is in place now. So we can give those anti-D immunoglobulins, those are called. So they can be given to those women who are rhesus negative, and due to that, the number of immune hydrocephalus has significantly dropped. So now the most common and almost more than 90% of the cases of hydrocephalus are due to non-immune reasons, and they can be cardiovascular, they can be hematological, like thalassemia and infections causing anemia. And in those infections, obviously, you can further tell that this, they are torch-related infections. They can be, then you can talk about those parvovirus and all those viral infections. And then don't forget genetic and chromosomal reasons as well, like Turner syndrome. So there can be some genetic and chromosomal problems as well, which you need to mention. And then sometimes just idiopathic. There may not be any reason for that, yeah? So how we diagnose that, yeah? So the diagnosis is just simple again as we do if you are asked to write an essay on adult hospitality, keep doing how this is diagnosed. Usually, on the scan, when they have the ultrasound scan, or following if the mother has developed any viral infections, that can also lead to obviously do the scans and also do the torch screening and make the surveillance, and we start the surveillance of the baby, then it can be picked up where we are expecting. And then, and obviously no amniocentesis that can add, if you're expecting any torch or chromosomal abnormalities, then we can, add that amniocentesis as a test as well, depending on which stage of pregnancy. Usually is diagnosed either on 20-week scan or after. It will be amniocentesis. So yes, so start straight away from saying fetal medicine referral. So these patients will be seen by the fetal maternal medicine specialist, and yes, in that tertiary care hospital as well. So how are they going to do? Obviously, they will be doing detailed, again, they will do the detailed structural scan to look for any cardiac abnormalities, any lung-related abnormalities, any renal atrasias, or any other reason, not atrasia, urogenesis, with any problems related to that. And then obviously the treatment will start accordingly. Now the management will be again in utero and post-delivery. And in utero management will depend again on the severity of the hydrocephalus. If it's quite severe or moderate, then obviously it will depend on two reasons. The first, if the cause is identifiable, then to treat that cause or infection in the mother if that was. Otherwise, we need to just do the paracentesis and remove the thoracic, the lung fluids as well, and then give plasma exchange, the blood exchange, and then give her red cell infusions to the baby, as a red blood cells infusion to the baby. So that will all be done in the fetal maternal medicine unit. The hydrocephalus, the risk of preterm delivery is quite high for two reasons. Number one, there can be a risk for this woman to go into preterm delivery itself as well, and the second can be, we may decide, that maybe clinicians decide as well, depending upon the situation and the severity of the disease of the baby. So, the main will be the treatment will lie again immediately after the delivery. So then you need to talk about that as well, like when these babies are born, what we need to do. So obviously they needs to be delivered in the units where all these preparations are available. So they will be required neonatal intensive care unit. Cot availability must be there, and ventilator for the baby, because this baby will require, they need to have chest and ascitic drain equipments present as well at the time of delivery. On the trolley already, there's the delivery preparation. Central line equipment needs to be there if the baby has been diagnosed with severe and group O rhesus negative blood. And once the baby is born, then depending upon the baby's APGAR and the condition, obviously they may need to just ship the baby straight away or start these interventions straight away to reduce that, remove that. The cord blood will be collected to take the cord gases, and direct Coombs test will also be arranged, and the blood group of the baby will be checked. Okay. That's the main. So these babies, obviously, then depending on the condition, they may need to have the airway maintained, and they may need to be put into ventilator. Obviously, they will need to correct their anemia, blood transfusion, exchange their, the blood. Prognosis is in moderate and severe hydrops is very poor. Unfortunately, they can, most of them can result into death of the baby. So this is the main. Now, in the discussion, this will be the outline you'll be talking about. In the discussion, then obviously they can pick up maybe one condition from there and ask you, okay, so if that happened in this, how will you proceed? Then you can go according to the class. But otherwise, this is how the sketch-wise you should just make your plan and idea that this is how I'm going to describe this. Okay. So try to look into all these recent talk.
Actually, ma'am, for structured discussion, will these questions be available to us from the beginning, or after we answer one question, they will answer the second question?
So sometimes there are, sometimes in some station, there may not be any questions at all. They will ask you, what is your diagnosis and how will you manage it? And then they just sit quiet, then you need to go. Sometimes there might be questions given already, then it's easy. You can just classify that. But I have seen recently, usually these questions are not present there. They might start with one question. And then, so since the online exam has started, actually, because they are also aware to make sure, because the screen is suddenly going to change after the time. From the feedback of all the candidates who have taken the exam, they are actually quite good and cooperative in that sense. The role players, if you start talking and you keep going on whatever you're explaining, and if there are marks for some specific point they want, the role player interrupt you and ask that question. The same way the examiners also interrupt you. So say if you have started giving the diagnosis and started talking and your diagnosis is not right, the examiners are asking you, would you like to go back and look into your investigations again? Do you want to go back and look into your notes again? So they are helping. So they have made it quite easier and straightforward as compared to before. Okay, so don't worry. It won't be the case that you start some wrong discussion or just some valueless point, or you keep going on and on and on that, and the examiner will stay quiet. No, they will.
No, my concern was when to stop answering a particular question so that they can, if you don't stop, whether they will not ask the second question. That's what I am.
They will. And if they're not asking, it's always a good question. It's always a good practice. You do your start beginning, and then you can always ask them to say, are there any specific questions you would like to ask me and I'm supposed to answer them, or you would like me to give you the overall management? Yeah, keep it again a natural discussion you will do with your colleague, just like as you're doing this with me. Yeah, you can ask me by saying, are there any specific questions, ma'am, you're going to ask? Or I just go, yeah, just same way, speak to them as well. But usually questions are not given in the beginning, most of the time. They will just simply say management, and the word management basically include everything. Yes, the information gathering, your examination, your investigation. So just keep going. And in the beginning, yes, it's absolutely okay to ask them. You want to ask me there is any specific structure questions I am supposed to answer? So this one we have done already. So this is like, your unit has quite high cesarean section rate. So we have done that already, like 39%. Okay. Only 5 AP. Okay. Okay, that's the next one now.
Is Reena Kumari here? Reena Kumari? Shazia? Shazia. I think then it's me. I will take this.
Okay. Take your 2 minutes. You can start now, Ramida.
Good morning. I'm Dr. Premila and I'm ready for the structured discussion. So we have got a patient who has delivered a 4 kg baby by forceps delivery by me. The head has been delivered, but I'm not able to deliver the shoulders with traction. So I suspect it's shoulder dystocia when even after the delivery of the head, after 1 minute of regular downward traction, if I couldn't deliver the shoulders, I'll suspect that it's a shoulder dystocia. My immediate action will be to call for help. That will include the midwife coordinator and experienced midwife, experienced obstetrician. If my consultant is on the floor, I can call him immediately. The neonatal team has to be called and the anesthetist will also be alerted. I'll bring the patient to the edge of the table and ask her to stop pushing. And if somebody was giving fundal pressure, I will ask them to stop that also. And I'll ask the midwife coordinator to reassure the patient and tell her not to panic. And then the first thing I'll be doing is to do the macrobird's maneuver, where I'll ask my assistants to flex the hyperflex the thigh and abduct it onto the maternal abdomen, so that it will slide the pubic symphysis little upwards and will increase the anteroposterior diameter, and thereby the shoulder can be delivered. And most of the cases, 90% of the time, this will be able to disimpact the shoulder. And if with that it is not possible, I'll ask the midwife to give suprapubic pressure in such a way that the pressure is given on the posterior surface of the anterior shoulder, so that this acromial diameter will be decreased and the shoulder can be moved to the oblique line. With that also, if the shoulders are not being delivered, then I will have to do the enter maneuvers. So before that, I will consider whether I have to put an episiotomy, so that it will give me enough space to do the enter maneuvers. So in the enter maneuvers, depending upon the situation and my preference, I can either do posterior arm delivery or the rotational maneuvers. In the posterior arm delivery, I will put my hand through the sacral hollow, try to reach up to the cubital fossa, and then give a jab at the elbow, so that the arms will flex, so that I can bring down the arm and deliver the posterior arm first. Then once the posterior arm is delivered, the anterior shoulder will come down. If that is not possible, I can try with the rotational maneuvers. In the rotational maneuver, the first I will try Wood's corkscrew maneuver, where I will be giving with one hand, I will be giving pressure on the posterior surface of the anterior shoulder in the clockwise direction, and the anterior surface of the posterior shoulder, so that I can rotate the anterior shoulder into the posterior way. The basis of this is the pelvis, the anterior inlet is at a lower level than the posterior inlet. So even though the anterior shoulder is stuck behind the pubic symphysis, the posterior shoulder has already crossed the pelvic rim. So if we can rotate and bring that anterior, that can be delivered. If that way this cannot be rotated, we can do the reverse rotation, or Rubin's 2 can also be tried. And if still it has not delivered, I'll make sure the consultant is available and the anesthetist has been informed. And and if the epidural is not there, I can even turn the patient into an all-fours position and try to do all these procedures again. And as per the instruction of the consultant, I can then consider doing either a cleidotomy or a symphysiotomy, or else I can try to do it Zavanelli and put the head back in and take for an emergency cesarean section. And once the delivery has been done, the pediatrician will be there on the floor to take care of the baby. The cord blood gases will be paired, cord blood gases will be taken, and I will be anticipating postpartum hemorrhage and will be carrying out active management of third stage of labor. I will properly examine the perineum and the cervix and the vagina and look for any tears, and I will be suturing them properly. And I'll also have a look at the baby and ask the pediatrician about the follow-up of the baby regarding whether the baby has got any problem with moving the shoulders. And after the delivery and suturing, everything has been done, I will document everything properly in the proper proforma. And I'll make sure I have to specifically write down which was the anterior shoulder, so that if later on, if due to some other problem, if the baby develops some difficulty in movement of the other limb also, it should not be thought that it is due to shoulder dystocia. So particularly I will record which was the anterior shoulder. And after this, I'll be writing an incident report also, and we will be doing a detailed analysis on that. And I will debrief my team about what has happened, whether we should have anticipated this, because it is a 4 kg baby, and when we are applying an instrument, we have to anticipate shoulder dystocia, whether there was any other factor.
Okay, so is it predictable then, and what are the factors which can help you to predict shoulder dystocia?
Yes, shoulder dystocia, by conventional risk factors, only 16% can be predicted. But there are risk factors like previous history of shoulder dystocia, or patient having diabetes, macrosomic baby. If diabetes, if it is more than 4.5 kg, and non-diabetic more than 5 kg. And then if it is a past dated pregnancy, patient is a very obese patient. And during labor, if it has been a prolonged labor, where there was delaying descent of the head, second stage delay, and where we see that the head is trying to, with her pushing, the head is trying to come out, but again it is retracting inwards, which we call as the turtle sign. So if these things are there, we have to anticipate a shoulder dystocia.
Okay, and is it preventable?
Shoulder dystocia is not preventable, but if there is a previous history of shoulder dystocia, and if it is a diabetic patient and the baby weight is more than 4.5 kg, then we can counsel the patient or recommend the patient that by doing a cesarean section, we might be able to prevent a shoulder dystocia. But other than that, it is not preventable. But we have to anticipate it.
What advice would you give the women who have a shoulder dystocia for the next pregnancy regarding mode of delivery?
That depends upon how the baby's condition has fared. If the baby had a significant shoulder dystocia that led on to brachial plexus injury and the baby has got residual defects, then in that case we will counsel her to undergo cesarean section electively. But otherwise we will have to see the baby weight this time, and depending upon the baby weight we have to counsel her.
Okay, and what will be their counseling? What are the cutoffs of the weight, and how you want to relate that with the weight?
Yes. If the baby weight is less than 4 kg, and if the patient doesn't have diabetes, then the chance of having shoulder dystocia is only 1%. But if it is between 4 to 4.5 kg, it will increase to 10%. If it is more than 4.5 kg, it will be doubled, around 20%. Whereas with diabetes, all the chances are almost 2 to 4 times more than what has been said. That is with if the baby weight is more than 4.5 kg, around 30% chance of shoulder dystocia is there. That counseling I will give the patient.
What is the importance of documentation in cases of shoulder dystocia?
We have to documentation in the form of when was it diagnosed, when was the call help given, when was the support given, and at what time each of the manuals were carried out, and within how many minutes from the delivery of the head the baby could be delivered. Ideally within 5 minutes the baby has to be delivered, and also which shoulder was the anterior shoulder which had got the dystocia, because that will help in finding out.
Okay, that's fine. Thank you. Thank you very much, Pramila. That was nicely done.
Thank you.
Yeah, so this is how it should be done. So this is one of the emergency protocols. Yeah, so as we talk about when we did cardiac collapse as well, that in these protocols you must just keep saying step after one another, and they must be said. The protocol means you can't make the changes and alterations. Guidelines are there to help you to say you can deviate from the guideline, but the protocols must be followed as they have been defined in the standard gold standards, national standards, right? So we understand, obviously we do have a very clear guideline, RCG guideline on that, and that very clearly gives all these steps, which Pramila has all described nicely, exactly the way it should be. Just few points I would just like to add here. I'm not going to go on because they were all fine. So as soon as you realize that this is shoulder dystocia, call for help and ask to, the team will include the obstetric consultant and then your anesthetist and your pediatrician. And then again, like cardiac arrest, it must be clearly said this is a case of shoulder dystocia in room number 4 or whatever that room is, and the doors of the delivery suite must be opened. And then yes, you see, so the identification, how you identify again, everything given in the guideline, how will you identify this is a shoulder dystocia? We see those certain signs from the head. The head is actually, very tightly back to the vulva, is not coming down, and turtle sign. So they are given those 4 steps, and Pramila has said them beautifully as well. So this is the way you identify. Then the step needs to be given. The only one thing, the the episiotomy. Yes, you can give the episiotomy. I wouldn't encourage to say that I will do the episiotomy, that will provide me more space. Before that, you need to say that you will put hand into the the hollow of the sacrum to assess the available space, and then if required, I can consider with the episiotomy. Because the episiotomy as it is, that doesn't obviously contribute towards the success of the maneuvers. And then yes, the rest of the steps are fine. The order you describe them, all 4s. I don't know whether you said or not, but that could be all 4s could be right in the beginning as well.
I said
of the person.
I said.
You
but
did.
With epidural, can we do all 4s?
Well, that depends on the mother's movement, because it will be assisted position anyway. So if we can't do, we will do. And then yes, all the rest of the procedures were fine. At the end, then again, yes, the pediatric assessment of the baby, cord blood for the gases, and those values must be noted in the documentation as well. And then it's very important to do the counseling of the woman, as you said, you will ask the coordinator midwives to explain to the women, and also to the birth attendants as well. So in addition to explaining them that this is what is happening and we're trying to deliver the baby's shoulders by doing these all maneuvers, and there will be some people around, and not to worry about it, we need to also alert them the possibility of the postpartum hemorrhage and also tears. So you did that nicely. Yes, after the delivery, you need to have a good examination under the line. Good light, particularly if you suspect any extension of the tears, and appropriate suturing. If required, you can even take the women to the theater if there's any suspicion that it might have extended third or fourth degree tears, so that you can put in the proper position and the proper good theater light to do the appropriate suturing of those. Documentation, yes, documentation in this particular case is very important. I mean, the documentation obviously is the important part, but this particular case, the shoulder dystocia, is the high litigation rate. That's the highest reason physicians get, they get called to the court because of the complications. So yes, the documentation must include the name of the surgeon who was performing those, and the other personals present, time of the delivery of the head and the shoulder. Then you rightly said it must be identified what was the anterior shoulder at that time, right or left, maneuvers and the order of the maneuvers performed. And for that reason, when these emergencies start, we save, from the helping people, we save one of the persons, we ask them to actually write down the timings of all of these events. So they must be put there as well. And then maneuver sequence, when they were performed, the time when the shoulders were delivered. And then you need to write down estimated blood loss as well. Then you need to also write down if there were any tear, describe them, and the suture, general condition of the baby from EPGAR point of view, and then the cord gases and their results, they must be written there as well. And then neonatal assessment of the pediatrician, that will be part of that as well. Yeah, so that's like how the RCH performance. And you can just add that, you know, this should be on this particular, you can say that word, that according to the RCG performer, I will make sure I do this. And then yes, risk incidents and the team briefing to see how we did and was there anything else we could do or do differently. Good, that was nice. Any question before we go ahead?
Should we say reflection also at the end?
So should you say what?
Reflection. I will do reflection.
Yeah, you can add that one. That's even good. Yeah. There we can also, yeah, I can put that case for the reflection. Okay, so who is next now?
Selina. Selina, are you here? Selina. Anilasri.
Anilasri has said excuses. She's not here.
Okay. Sadia is also not here. Sapna.
Yes, I'm here.
Selina is here now.
Okay.
But I haven't revised this guideline for a long time.
Okay. Anybody who has revised recently?
Sapna. Sapna. Sapna, are you there? Deepti.
Don't worry, girls. If you
Reena D.
I haven't revised it in quite a while, but I can just try.
Okay, that's fine. So I know it's difficult for you guys while you're doing the duties as well, but I will be really concerned that it's such important guidelines points you haven't revised recently. So please put their bullet points in one paper. You don't have to go to the RCG site to revise it. Okay, mean just the bullet points. And this is the time now, you know, alongside whatever modules you are preparing, all these guidelines needs to be revised now as well. So I just need to take a call. I'm just going to put it on the hold. It won't be long, okay? Just a couple of minutes.
Ma'am? Can everyone else hear me?
Yes, Pratibha.
Has ma'am come back? What is happening?
I can't make out actually.
But the
I was
slide
also,
has now changed to another slide.
yeah, another slide has come, but I was not being able to hear anybody, so I was wondering. I was also thinking
Anyway, you have
I'll
not done the discussion, isn't it?
no, I don't know. Because ma'am was
No,
not
no,
saying anything.
you are the one who was supposed to do that part. So anyway, nothing would have happened.
No, I haven't done anything.
Yeah, thank God.
Okay, sorry, I'm actually on call today, so they had a bit. Okay. Right, so where were we? No, it was molar. Yeah. Stop here. Yeah. Okay. Yes, Selena.
Yes, okay, ma'am. I'm Dr. Reena, one of the exam candidates for MRCOG Part 3. I have gone through the discussion and I'm ready to start.
All right.
So,
Okay. So yeah, just follow these questions and.
Molar pregnancies, they usually present with a short period of amenorrhea. Sometimes they may have bleeding, and the size of the uterus is more than the period of amenorrhea. And they may present with features of hyperemesis. Sometimes they may present with features of pregnancy-induced hypertension. They may also show some signs of hypothyroidism and bleeding as well. And some rare presentations are sometimes they may present with respiratory failure and some neurological disturbances as well. So this is the way it can present. And now coming to the diagnosis, a scan, when we see a scan, we become suspicious of the diagnosis, and also sometimes there may be some grape-like vesicles in the form of vaginal bleed, which may create a suspicion. And so in order to aid us in our diagnosis, we go forward with a serum beta HCG investigation, and we also, the final diagnosis, however, is stamped after doing a histopathological examination following a suction and evacuation. And how should a woman, now if a woman is having persistently raised HCG titers after a pregnancy event, then we need to be very cautious, and we have to keep molar pregnancy in mind, and we need to we need to do a serial estimation of the beta HCG, and then we need to do a histopathological examination as well by doing a suction evacuation if the bleeding is continuous. And for this, we need to connect with the gestational trophoblastic center and take their specialized opinion with doctors who are experts and working in this field. So we need to collaborate with the gestational trophoblastic center in order to reach a diagnosis. And depending upon the whether the beta HCG titer is decreasing or increasing, the further management will be decided. And if the values keep rising, then we might have to sometimes go for a chemotherapy, and then an evaluation is done according to FIGO to check on the on certain factors like what was the pregnancy event, and what is the duration, and if there are any further signs as well, like if there are any signs of any metastasis to the lungs or any other or any liver or spleen, we will check on that as well. And then a scoring is done. If the scoring is less than 6, then we go for a single drug regime of methotrexate. However, if the score is more than 6, then we go for a multiple drug regime, which is known as the IMACO regimen. And the next is how to manage a twin pregnancy with partial or complete mole. So this scenario is quite a rare occurrence where one twin is healthy and the other is having a partial or a complete mole. So there have been some studies on it, and some cases rather, and these cases have shown that this has to be managed in a specialized center, and this pregnancy will be monitored throughout by the fetal medicine unit in collaboration with the gestational trophoblastic center and the consultant. And the pregnancy is a high risk one, and it may have many risks associated with it, like there may be a preterm delivery, there may be excessive bleeding, there may be features of hypertension, and there may be a IUFD as well. And so, however, this pregnancy under strict monitoring can be continued. However, to get
What
a
you
live
mean by strict monitoring?
We'll have to keep in mind the complications that might occur, and we'll have to monitor those complications. Like if there is an excessive bleeding, then we might have to intervene, and we might have to terminate. We might have to end up the pregnancy. However, if there are no complications occurring as such, then we can continue with the pregnancy. But we need to counsel the patient regarding the risk factors, and when she should report immediately to the consultant, and we also have to tell her that the chances of having a live baby it's a very low chance of having a live birth. So she needs to be counseled regarding that, and we have to give her adequate support also, because this is a very high risk pregnancy. And
Okay.
then coming to the next, in placental site trophoblastic tumor or epithelioid trophoblastic tumor, the best form of management is to go forward with a surgery, and this will also be done in a tertiary care with taking all proper precautions, because this can be a surgery where there may be torrential bleed. So this will be done by an expert surgeon, and keeping all possible risks in mind, and the blood bank and the hematologist have to be involved as well. And coming to the next, that what is the follow-up following a diagnosis of gestational trophoblastic disease? Regarding the follow-up after a suction evacuation, if the beta HCG levels, as we keep monitoring them if it comes back within normal within 56 days or 8 weeks, then we continue the monitoring up to 6 months, and that is from the day of evacuation. However, if the normalization of the beta HCG occurs after 8 weeks or 56 days, then we continue monitoring from the day of normalization up to 6 months. And so that is the optimum follow-up. And regarding fertility and HRT treatments suitable for women, it's once they have been through with the follow-up, fertility and HRT treatments can be done, but it would be a high risk, as
Hello? Yeah, can you hear us?
yes, ma'am. It has to be treated as a high risk while doing any kind of fertility or HRT treatments, but this can only be initiated after the beta HC levels have come back to their normal values.
Okay, so when you say treated as high risk, so what management plan will be? What extra or different plan we need to put in place for them as a high risk?
She has to be seen in a consultant-led unit, and we also have to liaise with the gestational trophoblastic center. So that is what I mean by high risk, ma'am.
So the women who are having treatment for infertility or HRT after gestation trophoblastic disease, we need to be in consultation with gestation trophoblastic disease center. No. Yeah, they can have it. So we don't need to. So be careful. That was nicely done. Thank you very much, Rina. You did cover most of the points and cover them very nicely as well. Just few things regarding fertility. Be very careful when we use the words, you know, high risk, and we will do the close monitoring. If you're saying that, then you need to exactly tell what it is, yeah. Because as we said, it's like it's a colleague communication, and you're supposed to use your you know, technical and medical jargon, and you need to be really, you know, you need to appear well knowledged here. So it's a discussion you are doing basically. Okay. So use appropriate terminology, and whatever you're saying, the testing or monitoring, what you're saying, all of them you need to clearly say these tests are this or this, yeah. So yes, that's fine. I mean, I brought them into the questions anyway, and that literally is the guideline, and this is how it appears in the exam as well anyway. And it did appear basically partially, you know, that the scenario where that woman started with miscarriage, and then she comes back, she was still bleeding, and she came back and beta HCG levels were high. And then she was diagnosed with a molar pregnancy. Then the discussion in that station followed all these questions, you know, how will you manage this complete mole, and what will be the follow-up, and about the chemotherapy and all those questions. So that's why it's really important. I mean, sometimes it may not just appear as very nicely as I have put as a medical school question, really. Sometimes it may be associated with the scenario, just like as I've given that scenario example, which has been appearing in exam a few times before as well. So then obviously this is what you need to then recall and speak. So diagnosis at the presentation of the molar pregnancy is not only just the hyperemesis. The most common is, yes, short duration of amenorrhea with hyperemesis. But then we do know the women who have a miscarriage, and if they are presenting with the persistent bleeding, they can present with the pregnancy test being positive after three weeks. Same way, even in the ectopic pregnancy, we have done the management of the ectopic, and then still their beta HCG levels are high. They need to be included for the investigations of gestation trophoblastic disease as well. So remember these few other presentations as well, yeah, other than the routine, one simple one. And the diagnosis obviously is just very simple: beta HCG and the scan. Yeah, so beta HCG remarkably higher level as compared to the for that particular age of gestation. And then very typical, I wouldn't say that a scan may be suspicion or maybe. We need to be very clear. The scan findings are very typical of gestation trophoblastic disease, yeah? Molar pregnancy, very typical characteristic appearance of grape-like cystic spaces appear on the scan. That's what we need to do. So how should women with persistent, I mean, you have to tell them after a possible event be managed. So you know, that just is again same guideline. You need to get them registered with the regional gestation trophoblastic disease. They will have weekly beta HCG levels, and then somebody who has been, you know, treated already, and then we if their beta HCG levels, that you said, if they return back to normal within 56 days, then they need a follow-up 6 months. If not, then, you know, we need to continue with that, but then we need to exclude. They need to have a review back again by the gestation trophoblastic disease center, as well as the gynecologist, to then have further scans to exclude neoplasia, gestation trophoblastic neoplasia. And if it is diagnosed to be neoplasia, then obviously you need to have the details of the investigation. Yes, FIGO staging, you must all know very clearly what are the features and characteristics to be added, and then according to the stage, single therapy or more than one therapy agents, and what will be the advice for the next pregnancy. Is any follow-up required in the next pregnancy? How long they should have the interval between two pregnancies. If they have used chemotherapy, they shouldn't get pregnant for 1 year. And then, so they're just simply, again, just the guideline really. Placental site trophoblastic tumor, epithelioid trophoblastic tumor, obviously they are well-known types of the gestation trophoblastic disease, so they will also be followed and managed by the gestation trophoblastic disease. After follow-up, you have the fertility HRT. Yes, their levels have come down to back to the normal when they were, then they can just routinely have their HRT. and their fertility treatments as well. For that one, we don't need to particularly, again, I mean, for the gestation trophoblastic disease, they are not experts from that point of view. They are more like the lab, you can say. They are not going to look into individual cases. That is just the gynecologists again, or fertility clinics who will be reviewing that, yeah? So if they are normal, all we need from gestation trophoblastic disease, the information is about their, that report that they have returned back to normal and when. So we can decide whether it's safe now to that interval has passed. And they can have obviously exogenous estrogens as well. Okay.
Hello, Dr. Sophia.
Yes,
Thank you,
please.
ma'am.
Do we need remember this staging means whatever there are some criterias, age and all these things, do we have remember or just
Then for this particular one, you need to, yeah. This is the fecal staging, oral pregnancy is important. So we need to know that. And that's not very complex, yeah. Just simple that scoring again, just from the bullet points from the guideline.
okay. Thank you, Dr. Sophia.
Okay, so who is next? How about management of twin pregnancy? Yes, thank you, Rania, for
Can I do
reminding this.
because
Sorry, ladies. I just want to answer that one. So the twin pregnancy, when there is one, the normal twin and the other one is molar. So you did talk about that, Rina. Well, what we need to talk here is we need to take a very, detailed counseling and discussion with the parents in the twin when the one is, the molar and the other pregnant. From two aspects point of view. Number one, we need to offer them to have the fetal karyotyping, and that is obviously invasive, obviously CVS or amniocentesis. For the surviving fetus, because there could be some chromosome abnormality with that baby as well. So that's the number one, with the risk of miscarriage. Then we also need to talk about the prognosis of the gestation trophoblastic disease, the molar, the other molar pregnancy. Obviously, there can be poor prognosis for that one. There will be high chance for that to develop into gestation trophoblastic in the neoplasia. And then we see delay in the treatment of that can result into poor prognosis. So that needs to be a very sensitive discussion need to take place between obviously the clinicians and the parents, and then offer them counseling, and then they need to take a decision, and that must be documented. Did that clear, Rania, your question, or is there anything else you want to ask? Okay, yes, Shazia, what was your question? Okay, who is next, Pramila?
Sujata.
Okay, Sujata. Are you with us, Sujata?
Yeah, yes, Dr. Safia.
Okay, great. This is for you. You can start now.
Yeah. Yeah, I'm Dr. Sujata, one of the candidates for the Part 3 exam, and I'm ready for the structured discussion. The case here is a 45-year-old lady who has come for preconceptional counseling. And so the first question is, what are the risks in very advanced age pregnancy? In very advanced age, the mother can have diabetes, hypertension, or any other medical comorbidity. So the risk to the mother is because of these factors, her pregnancy can be a high risk pregnancy, and there will be the control of blood pressure and diabetes can be altered during the pregnancy. Whereas for the baby, once she gets pregnant, there's a higher chance of miscarriage. There's a higher risk of chromosomal anomalies in the baby, can have preterm delivery, can have growth restriction, and yeah, and also depending on her BMI and her social habits, there is a higher risk for prognosis during the pregnancy. So whenever she gets pregnant, she'll be put on aspirin, depending on her factors, and also she'll be asked to take high dose folic acid to prevent neural tube defects. So,
Okay, you continue then. Okay.
yeah. So we will take a detailed history whether she has any medical problems, and we will optimize her medical conditions, and we will take her through pregnancy. What are the options for conception? Because of her age, her ovarian reserve might be less, and because of the medical comorbidities, she might have a difficulty in conception. So she may need the help of fertility specialists to conceive. So she might need the help of fertility specialist, especially IVF pregnancy, and because of that, she can have multiple gestation or higher order pregnancies. That also can put her pregnancy at high risk. Then what are the risks of pregnancy in very advanced age? So the pregnancy is a very high risk pregnancy. So once her medical comorbidities are optimized, and she is on high dose folic acid, and she's conceived, she'll be under a multidisciplinary care. She'll be looked after in the obstetric unit, and whatever she will be offered early dating scan and investigations, and then she'll be offered first trimester screening to rule out Down syndrome, because there is a higher risk of Down syndrome, and if that comes positive, she'll be offered a needle test to see whether the baby has higher chance of getting Down syndrome, and she'll be offered either termination of the pregnancy, or she can go forward with the pregnancy depending on how she feels about it. If she wants to go forward with the pregnancy, she will continue in the consultant-led unit, and at 20 weeks she'll be offered a morphology scan, and further anomalies will be ruled out. And since she has a higher risk of developing gestational hypertension, her blood pressure will be monitored, and at every visit at 24 to 28 weeks, glucose tolerance test will be done, and serial growth scans will be done from 24 to 28 weeks, and at 36 weeks, her mode of delivery will be discussed with the anesthetist, and She can go up till term unless she has any other medical comorbidities. When she goes into labor, there will be continuous monitoring of the fetal heart, and she'll be given adequate analgesia and one-to-one care. She can have a vaginal delivery unless there are any obstetric indications. And after delivery, active management of third stage of labor will be offered because there's a greater chance of BPH, and because of her age, and she will be encouraged to breastfeed. DVT prophylaxis will be given to her based on her risks, and she will be given advised effective contraception.
Yeah.
Yeah.
So that's all you done, yeah? Okay,
Yeah.
thank you. Thank you very much. Yes, you covered most of the points here. Could be a little bit more organized, we can make it. So for very advanced age pregnancy means the pregnancy is after the age of 45 years age. So you can basically make into organize into I will say into main three subheadings. Number one, complications because of her age itself, you know, with significant increases, obviously, risk of chromosomal abnormalities, as well as pre-existing conditions. Yeah, so at 45 plus, you know, the risk, and most of the people will have one or the other disease. You know, they can have already these systemic diseases like cardiac diseases, hypertension, diabetes. There can be some, they can have, you know, some pre-existing uterine surgery as well in one or other fine, you know, more likely to be as compared to, we say, young patients, maybe fibroid resection or any, you know, could be any that type of surgery for the uterine. So think about that one arm first, being that age what it can be. The chances of obesity, high BMI at the start of pregnancy, they are also high in this particular group as compared to other, again, young women. So that will be one side. So that means we need to have a full assessment. So we need to think about, yeah, if they have these existing conditions already, any one of them, obviously they're going to further add to the complications for the pregnancy. So then you will need to, you know, address that as well, that they need to be all of these. That just is a recording going on itself, rushing where it's wanting to. So there needs to be, they need to have proper evaluation. So they need to be a you know, detailed preconception counseling for these women and assess for all these conditions, get the appropriate physician or GP review, get the good control of the pre-existing condition before they embark for the pregnancy. So there's the one arm. The second one can be what maternal complications will significantly increase because of the this the age. Yeah. So yes, to think about the maternal complications first. So there will be increased risk of preeclampsia. Number one, the spontaneous conception rate is low, will be low because of the decreasing ovarian efficiency. So they're more likely to have assisted reproductive techniques used, and if they use that, obviously there will be more risk for the complications of the technique, the risk of multiple pregnancy, because of the advanced age. Then most of these women then want to have more than one embryo transplant. They want to have at least two. So obviously that increases the risk of multiple pregnancies. And then they can have a high risk of, so think about from the conception point of view, yeah, high risk of ovarian hyperstimulation syndrome, and then high risk of miscarriage, very high risk of miscarriage. That's quite high, about more than 50% really. And then they can obviously develop preeclampsia and severe preeclampsia, diabetes. They can be at risk of cardiac disease during pregnancy. First diagnosis of cardiac disease, you know, during the pregnancy. And then anxiety, their levels of anxiety and stress, and you know, the mental health issues can be quite high as well because of being anxious about their pregnancy. Then you can think about the fetal complications. So from fetal complications point of view, yes, miscarriage, very high risk of chromosomal abnormalities, very high risk of Down syndrome in these women, challenging and difficulties actually basically as well then to provide them the screening testing for Down syndrome. and also then depending upon those results, how to proceed further. That can be quite challenging as well, because they, from the scoring point of view, they are more likely to have the factors which will put them into already below the cutoff value, 1 in 150 or 1 in 250. So that further will increase the challenges to the diagnosis. And then fetal anomalies, the risk of fetal anomalies is high. They need to be booked under fetal maternal medicine. Then the risk of preterm, growth restriction is quite high in these babies. The risk of preterm delivery, which can be both ways. One maybe, for fetal complication or anything, it's how the women can go into preterm labor. They are quite highly likely to go into preterm labor as compared to the other women. And then there could be a iatrogenic reason to induce them earlier as well. These women then think about, they must be reviewed by the anesthetist at 34 to 36 weeks, and then the labor process. They are likely to go into spontaneous labor as well. The mode of delivery is not significantly, affected because of the age factor. Indirectly, it is, yes, obviously, if they have developed any complications, severe complication like severe preeclampsia or cardiac disease, they've been diagnosed, or are there any fetal complications. So because of that, the relative risk of cesarean section will be increased in these ones. And then obviously these children of the babies, they have quite high perinatal morbidity and mortality as well. They're more likely to end up in the NICU and then, respective. So these are the things you need to keep in your mind, yeah? So for that, this is how you will say these are the risks, yeah? And then, okay, what are the options of conception? So we have talked about that already. It depends on them. If they are multi-parents already, like they have 1 or 2 children already, maybe when they were in 30s, and though maybe now they are in a new relationship, and that's why. So the women who already have some spontaneous conception, they are more likely to have the spontaneous conception. But when they decide, again, because they're very well aware of decreasing efficiency of their ovarian function, they want to have artificial reproductive assistance. So that will all depend again on their ovarian reserve. So they can have, just the routine IVF option. However, we need to talk about the risk of, these are high risk of Down syndrome and other chromosomal defects. Now, there can be a discussion, the possibility after informing them about this high risk of Down syndrome in these babies and other chromosomal abnormalities, which can result into obviously long-term severe learning difficulties, disabilities as well. The discussion can be considered to encourage them to use donor ovum from a young woman. That will obviously reduce the risk of these chromosomal abnormalities and some other complications for the baby. However, the risk of the maternal complications obviously is going to stay same, like preeclampsia and diabetes, and they can obviously then have detrimental effect on the fetal complication, increasing the risk of perinatal morbidity and mortality. So that's about it. Then regarding the Down syndrome screening, these women, again, we need to take a really detailed counseling with them, because they're highly likely to already to be below the cutoff value of where the invasive testing is indicated. So these women then can be offered obviously 2 options. The first option is to offer them a cell-free DNA test, because that is more sensitive. That can diagnose more than 90%, well, not diagnosed, I mean they are more sensitive, about 90% indication about the Down syndrome. So that's the one option we can offer them to basically reduce that window of probability. And then after that, they can decide whether they want to go for the invasive testing or not. Now, whenever we offer, whether they are this advanced age women or even the other women, when we are talking about amniocentesis and CVS, invasive testing for these chromosomal abnormalities, we must ask them first and prepare them, what would you like to do with that result? Okay, so if the result is positive, the result says diagnose the baby is affected with Down syndrome, what you want to do with that? Are you willing to continue with the pregnancy, or you will consider to terminate the pregnancy? And if they don't want to consider to terminate the pregnancy, then the next question we must put to them is to say, so how you feel about having that test, and then would you then like to take the risk of 1 to 2% of miscarriage following amniocentesis? And then warn them as well, kind of, then we, you know, there can be possibility that, you know, although it's only 1 to 2 out of 100 risk of miscarriage, but in case, you know, as a complication you have miscarriage and that actually Down syndrome come back as negative, the baby is unaffected, that will have the implications for you. So you need to have a think about that as well, what you want to do. So always say that to whoever the woman is. And then they need to be, yes, they need to be then booked for their anomaly. Detailed scan must be done by the fetal maternal medicine. So starting from the care of the pregnancy, yes, so we started the conception, so let's see they are pregnant, they should be early booking of these women. So routine antenatal testing, and then depending upon if they have any pre-existing condition, they need to have obviously MDT care of this, and they need to have more frequent appointments with their physician, respective physicians, whatever their condition is, for more tighter monitoring of their condition to keep that under well control. They need to be started on aspirin from 12 weeks. And then the women, obviously, who are already have diagnosed with the hypertension or diabetes, they will require uterine artery Doppler at 24 weeks. Fetal maternal medicine scan we have talked about already. They will have gestation to blastic disease screening. Sorry, they will have diabetes screening at 16 to 18 weeks, and then that will be repeated. If that's negative, then that will be repeated again at 26 to 28 weeks. Let me get to the pathway. There is a TOG article, and there is a very nice pathway given actually at the end. Only if I can actually get this down. No, it's not coming down. Anyway, so that is like, trying to squeeze it to bring it down, but it's not moving. Anyway, if there is a TOG article, I can send you the link on WhatsApp if you guys can't find them or you don't have the access to that. But if you just Google very advanced maternal age TOG article, it's a free access article, so you all can see that. And at the end, there's given this nice pathway is given in both cases, if there's a singleton pregnancy or it's a multiple pregnancy. Yeah. So just like as you can see here, like preconception counseling, we need to start them on folic acid 400 microgram, or if they have their risk factor, then 500. They need to be seen by their physician for optimization of their condition and body mass index. If they're going for ART, we need to discuss about the single embryo transfer as compared to two, and then that you will do obviously by telling the complications, increased risk of complications with the multiple pregnancy. More increased, you know, more severe preeclampsia, diabetes, more chances of that, and then high risk of preterm labor as well because of the multiple pregnancy. So then they have given different conditions, you know, if they have these hypertension, then you need to obviously have a hypertensive review. They need to have echocardiogram, their renal function, renal imaging. Then as we start, like because of the pre-existing maybe some 1 or 2 diseases and also BMI and age, they're more likely to have some risk factor for VTE. So we need to do them, you know, all these women must have at the time of booking or even preconception, they need to have the VTE risk assessment done, and then we can discuss and start them an appropriate VTE prophylaxis. And then it continues that pathway basically, you know, further, you know, mode of delivery risk assessment we have done, then start them 150 milligram aspirin for 12 weeks, and then they have given some, you know, pathways on both sides for the singleton pregnancy and then for the multiple pregnancy. So early referral to high risk antenatal clinic, fetal maternal medicine if required. PAPE measured and noted, significant epilepsy 0.4. So this just like again, these are just those challenging how we're going to interpret how we are going to interpret the results of Down screening, yeah, and then offer them. I have explained already non-invasive prenatal testing. Regarding, you all keep asking all the time, is there cell-free DNA test or NIPT, they are NHS funded or not? In some hospitals, in some trusts, they are funded and some they are not. So there is no clear at the moment. However, some hospitals, like if somebody like this woman who is 45 years age, then there can be a discussion can take place, and that can be provided by the trust if they already are not funding that. Okay? So there can be the reasons that they can have it privately done. So yes, so there is a nice clear pathway given, which you all can see. So I would recommend everybody just to go through that before you appear in the exam. Okay, so COVID, just read on the guideline. Sorry, not the guideline. There is still no clear guideline about, because this COVID is ever changing every day. But obviously there has been a guidance paper from college regarding the vaccination. So just read that. I'm not going through that because, to be honest, I haven't seen it in last 4 or 5 weeks. So I'm not quite updated with that, and I don't want to tell you something which may not be updated. So just on the college life science, the COVID guidance about pregnant women, just read that one. That's not very exhaustive article. The guidance paper, and then again make sure, like in the last week before the exam, just double check that as well, had that changed or anything. It's unlikely for the COVID, and I don't think it will be fair to bring the COVID in the exam, to be honest, because of just everyday changing things with the COVID. Okay, so that just is the previous regarding trying to do whatever. Okay, let's see then if I now bring it down. Sorry, my screen is frozen. Couple of other things I just wanted to make sure. So now in the exam, obviously, when you have these cases, in the exam, when you have those cases, we when we're doing the course, we have actually put the summary already about the results and the scan report and the medication. We did one scenario, you guys will remember, where that woman has presented. She's presented with fainting and low oxygen SARS. That was case of VTE, where we said that a dose of the her prophylaxis was missed on second day. So we put in the summary, but in the exam it won't be written in the summary, right? So you will have actually the papers in those 2 minutes. Okay, so so in the screen, make sure that you keep scrolling down to the screen to see, there will be the maybe operation notes, and then below will be the drug chart and the investigations. Everything will be given there, so make sure you scroll the page down so that you look through everything. Okay, very simple. Obviously you are not familiar with the operation notes and stuff which is given, on the name and patient, everything is written over there. The operation notes, because they're electronic entry we do here, most of these things now. Operation notes, I said, like, there are performance, we use the performance. So those operation notes, and when we use the performance and in electronic one, the typing and this may appear green. Okay, so don't be confused that that is something different. No, that is because we have clicked that performer so that we can enter our entry. So that might appear green on the screen, just making you guys familiar with. That doesn't necessarily mean anything different. Okay, so there will be quickly scan to see, quick things, as they mentioned about any complications, and estimated blood loss will be the important thing to pick up from the operation notes. Okay, and any other pre-existing. Then you go to, then come say the drug chart. In the drug chart again, quickly just make sure about the doses, have they been given. So this is how, can you all see the drug chart? Yeah.
Yes.
Yeah, so just like, this is the prescription say given, and then there are timings given, right? So once in a day, or sometimes they have actually marked circle around the timing. So say this is amoxicillin 3 times a day, and then on the top here it will be the date. You all have these drug charts, you use that. Yeah, you are familiar with this. So this is the date, that day. Then you need to make sure in that day quickly, that have the both doses given, for that date. Were the both doses given? If there are 3, are the 3 given? So the dose given is usually mentioned. The nurses who are doing that medication, they are supposed to put their initials. Okay, so AB, 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 so AB. So what you need to see under this date, you need to make sure in front of all these 3, have these 3 doses given? Quickly scan, have the doses all been given? Were there any doses missed? Yeah, just quickly look for one date, just make sure, okay, this 3-time day, just quickly, it shouldn't take few seconds for me to make sure. I don't need to clearly focus. Yes, I can see all these regular, there's no column missing. So yes, there's no problem in the medication. So there was a scenario in the last exam, and it has been appearing basically before as well, where they have given you basically the operation notes, and after that there are Meo's chart as well. So that lady basically had some large cyst removed, or abdominal hysterectomy or something, some surgery, major surgery she had, and then after that she collapsed, and then she has a pulmonary embolism. She has been managed already. She has been given those, whatever therapeutic, low molecular weight heparin, whatever needs to be given, that all has been given. She's recovering non-ICU. So the operation notes are given, the ICU notes are given, then Meo's chart is given over there as well, telling what of the conditions are. And then when the station starts, then obviously the examiners start by saying, can you summarize and tell me what that is? In that one, different people kept struggling with that by saying they start again just the way we do here, that the woman presented with, she was collapsed. They are again starting with the management. This needs to be done, this needs to be done, and this needs to be done. No, that woman has been managed already. You don't need to worry about the management. You can see the management has already been done. The important thing for you to see is in the management with the treatment charts, the drug chart, or the management is given to see, and the meals as well, chart quickly on those alarming signs. Has there been any action missing? That was about the risk management, that station. Okay, so in that one, basically, there was one dose of anticoagulant missing, PT prophylaxis missing on second day. So say the morning dose was given and the evening was not given, say, for example. Okay, so if you would have looked at the chart. So, but anyway, when the candidates were doing that, the examiner was telling them to say, would you like to go back to your notes and review to see, or you would like to have a, what it is. So basically, there was one dose missing. So there was purely a station of clinical risk management. Okay. So we have discussed that many times already. So what you will say, you will summarize the case there by saying these, and this woman had these risk factors for the VTE. I can see she was started on these one, but the dose on the second of that day was missed. And then she had this collapse. Then you need to comment on the management, was that appropriate, according to the protocol and the guideline that was given. And then you need to say no. Then the main part of chunk of that station should take about now how we proceed from there. Okay, so then you need to say no. Obviously, somebody, if she was not high risk for VTE otherwise, and she was just having prophylaxis because of the surgery post-op, then you need to say that although missing one dose, if she already have 2-3 doses and there was only one risk, the missing only single dose will not particularly increase the risk of her having this PE. However, because that error has happened, that can be counted towards that. Okay, and if they can be, then we can say that there can be no medical, legal, and legal consequences of that as well. So how we're going to proceed is, the first thing, we need to be very honest and open with that woman. We will accept that error. We will, explain her as well. And then obviously we need to find out why that happened. So first of all, tell the woman that error has happened, share the events, and then also explain her as well that although it is quite unlikely that would have contributed to her PE risk, unless she was actually classified as a high risk already. And then we miss the dose. Then obviously we need to say that it may be the possible reason. All right. But even if it is not, we still need to accept that error. And then obviously, depending on the woman, just as we say in multiple other scenarios, depending upon the woman reaction, what she feels at that stage of time, we will reassure her. We're going to, put the incidence form, and then we're going to analyze this risk to see why this happened. Yeah, because there is a robust system in place. The medication, when the nurses who does the medication for the patient, that nurse basically have a dedicated session, and she should not be, as part of the pathway, she should not be interrupted and called for any other duty or any other, the job or the task until she completes the medication of all the patients. And that measure is in place to ensure that obviously she's not distracted, to avoid all these errors. So we do have that system already in place. However, still we failed that medication. So we are going to do detailed analysis to find out the factors and the reasons what happened, yeah, where things went wrong. and what we can't do then, and we will, the lessons will be learned, and then we will definitely put the measures in place after identifying those factors to rectify them, and also to ensure that it does not happen in future again, doesn't get repeated. And obviously that, the outcome of that incidence analysis will then be discussed, and the learning will be then, discussed in a team meeting and disseminated in the team in a non-anonymous manner. And then, if the woman is satisfied from our reassurance, that's fine. If she is quite upset and angry about that, and she express the wish to complain or sue the trust or whatever, we will facilitate her. So we will encourage, I won't say encourage, we will say to her that's absolutely okay, and that's her right. If she feels she would like to go ahead with the complaint, we will facilitate her with the process by providing her the contact details, and also provide the details of the procedure, how to put the complaint in, and also to explain her the procedure of complaint and the responses when she will be able to hear back. Okay, and then obviously this can be quite traumatic and upsetting experience for the patient, particularly when they feel it has happened because of the error or the fault by the clinical team. Obviously they can feel quite angry about that. So we will arrange appropriate counseling for her as well. The same way, the relatives, the attendant or the partner or the relative, they also need to be with permission of the patient. If patient would like to, they can be debrief about that as well, and explained and apology offered. And then at the time of discharge, all these women who have some complication, make sure immediately after surgery, when they recover consciousness, we talk them. It's very important just before the discharge, again, some of the senior like ST5 or beyond, go and see them, because immediately after the surgery, they still are like some effects of anesthesia. They're very unwell. They may not be logically thinking at that stage, but then in the rest 4 or 5 days when they were on the ward, they might have some question which they want to ask right at the time of discharge. So it's very important for these women to be seen before the discharge being done. And then obviously we need to have a comprehensive and proper discharge summary to hand over the care to the GP, with a clear plan after discussion with the hematologist. How are we going to, and what anticoagulant we're going to continue with that, with a clear plan of the duration, doses of that, also to ensure the support of the woman which she has at home, partner or whoever. And then also, if say, for example, if you're putting her on warfarin, to make her appropriate appointments to come back for the follow-up for her blood test, INR. Okay, so hematologist. So this is how you're going to actually complete that one. And then obviously, yes, the team briefing, the risk assessment, we have talked about that already, to find out what that is. So this is how that station needs to be conducted. So yeah, so just be aware. Okay, so the drug charts do look all sort of different things, different colors. Some of them can have that's oxygen prescription chart. No, this one. So on the drug chart, now I don't know why it's not getting to the screen. There's something else that might be down here. Anyway, forget that. So how the drug charts usually are, basically, if you can look this part of the screen, I'm sorry, I'm not very good. Anyway, so on the top of this, this everything has decided to embarrass me today. Come on, please, don't do this to me. No purpose of opening them already. Let's open them again. Inpatient drug chart. Okay. Anyway, so the drug charts, usually the standard drug chart used in NHSR, here it will be like the details of the patient, name, hospital number, address, and all that. On this side usually is the you know, again, inpatient or whatever those it is. Now the top here usually is once only prescription, right? Something which we are only given for once, maybe morphine, one single status. So usually the first part here is, now you all can go back and look at those drug charts, is about the single only, and then is there your regular medication. Okay. In someone, just quickly look here, it usually is the regular medication, but in someone they might have the in some trusts they might have PRN, like when required prescription, but usually it's the regular medication after once only, and towards the end of the chart they will have once only when required prescription. Yeah, once only, then regular medication, and on the second page maybe towards the end will be when required kind of prescription. So just quickly, I mean, you guys should be able to just look, it's a routine thing. I hope everywhere it's same. Yeah. So, and then simply, as I said, like look at the when the drug is written in the regular prescription one, just look at the timings and just make sure they have been given. About the drug chart. The investigations, how they appear, they are usually straightforward. The abnormal investigations here, they are given the range. Just randomly clicking everything on the screen. So in the investigations, obviously, yeah, so investigations, you know, they have this here on one side will be the name, whatever the investigation is, then the result is given, and then in front of that, in the bracket, the range is given as well. It's very common, almost I feel everywhere it should be the same. The abnormal results are usually either they have highlighted the lab in bold, or there will be even a strict sign on that one for you to quickly pick up, okay? Otherwise, the ranges are always given over there for you to be, other than just very, you know, the common one, hemoglobin and stuff. But for all the investigations, the normal range is given there as well for you guys to quickly look into that. This is how you can quickly scan your notes. Anything from that point of view you want to ask from the notes and stuff?
So in the exam also, will these abnormal investigations be highlighted?
Abnormal investigations, yes, they are either in bold, or as I said, there will be an asterisk mark on them. Otherwise, next to the value in the bracket, the normal range will be given anyway. So you can just quickly scan to see that's normal. Yes? Okay. So that was one station in my mind. Then, one of the candidates, he's doing one-to-one with me. He told me about, you know, the sterilization station, reversal of sterilization station where the woman. So there are two different type of reversal of sterilization stations appearing. One is that simple one where that woman have the sterilization done about 5-7 years ago, and then now she's in a new relationship and she wants to have. That's the typical one which we do always in our course. So this time in one of the days in UK exam, the station appeared in a way where the role player was an Asian woman. And you know, her name was something Aisha Malik or something, and she is like, so she has three cesarean sections previously. Her last one was about 2 years ago, last cesarean section, and then she had a sterilization done with that cesarean, and now she has come back and she's wanting to have a reversal of sterilization done. Okay, now if this particular station, again, she was quite young as well, 31 or 32. So again, if you follow that template, basically, you know, in the beginning when we asked her, okay, so, you know, you have these same sections. So would you like to tell me why you chose to have the sterilization done? Because sterilization is not one of very common options we often are encouraged these days in presence of long-acting methods, which are, you know, are not permanent and they are equally effective. So ask that question, encourage, and she said, well, I have that done because that was my third child, third section. I have 2 daughters already. The first one and this third one, I had a son, and you know, my husband wanted me to have that done as well because, you know, he didn't want to have more daughters. Now, if you don't ask that explanation actually to her, particularly by saying, now you can understand why sometimes just small sentences, if you don't say, you can miss the whole theme of the situation. Yeah. So if you actually don't ask her particularly why you chose this to have at that stage, what was the reason for you to having, because we don't encourage, this because of these, she won't volunteer that information to you. And as soon as she volunteer that information, that the daughters and all that, I will be worried about the domestic abuse and all that going on. Okay, so before now I go into the details of how we're going to do and can we do or not, I need to know first, make sure here now about her, that aspect. Okay, so from in that particular station, then you need to ask that woman to say, okay, I see, right, okay, so your husband wanted, and it's very common, we know, apologize me, obviously that's for the learning purposes. I don't mean to be racist or anything like that, but we do understand in our Asian culture, there is a cultural style. The people want to have the boys, the girls like 2 or 3, or they feel a bit stressed having more girls. So that's the background here. Okay, and then these women, because it's a cultural aspect, these women may not take it as a, like it comes under the abuse, so when we ask that woman, I don't know, because that candidate didn't ask that, and he failed basically to ask that. He went all through talking about it's not funded or whatever, that story. So but that woman, when we will encourage her to say, okay, so your husband wanted to do that, so what was your opinion at that point of time? Like, was you also wanted to have sterilization? Like, you also wanted to? It's very likely the answer which can come back will be, yeah, I mean, he wanted to do that, and because we have 3 children or 2 daughters and we had a son anyway, so I also thought it's okay, I have a sterilization done. And that baby actually unfortunately then dies after 2-3 months. And that's why now they were again, they need to have a boy, a son again. So that's why she's here now to have the reverse of sterilization done. So this woman, we need to basically help understand to say, so okay, so that's reverse of sterilization. You can briefly tell her about the reverse of sterilization procedure. Before that, check like how you feel your relationship with your husband and the rest of the family, because we do understand in this particular culture, it's not only the husband, it's the in-laws as well, sometimes mother-in-laws, sister-in-laws, and they do have influence on that as well. Like they can also, then the women feel that pressure of that demand that they should produce a son, a child, a son. And then there are further pressure on them. They can be divorced even because of not having a son. There will be a threat of husband getting married to another woman as well, for the son. Okay, so in the background you need to keep that aspect in your mind as well. So I will ask that woman then to say, okay, so do you feel, is that again, you yourself also wanting, you want to go through, because there are very risk and complications associated with the reversal, which I will discuss explain in detail in few minutes. But before that, I want to establish, do you also willingly want, to have the reversal done and try another baby? Or it's just that you feel that pressure and demand from the husband and from the family? And it's very usual for these women actually to answer you back to say, no, I mean, that's quite normal, isn't it? They want to have the son, so that's fine. Yes, that's absolutely okay. They want to. Would you like to tell me how you feel about it? Forget what your husband wants or what your family want from you. Okay, so established. Her decision is volunteer. What she's saying, her consent which she's going to give or wanting is volunteer, and that excludes. So do you feel like you get like kind of you face any maybe unhappy mood from your husband or from the family, or any aggressive behavior, any pressure because you don't have a son, or so establish that one as well. It may not only be the partner, it can be very commonly the family pressure as well, and the violence, you can call it abuse from the family as well. And then you will say, okay, no, that's fine, I can explain you, but I will really like to make sure for you as well to reassure you, take this decision only if you yourself want to go. And then start the discussion from the simple main point first. Let me inform you, first of all, the reversal of sterilization, unfortunately, is not funded by NHS. So you will need to pay for this procedure. Okay, no, I'm just trying to obviously imagine possibilities here, because I don't have the insight, because that candidate didn't go that route, so we don't know what she was saying. So when she said no, if this woman particularly say, well, really, no, I can't pay for the procedure, then here, like the other woman, we can't just simply leave her by saying, well, you know, because that was your informed decision that you paid. So this is not funded. This woman, I need to consider, if we don't provide her reversal of sterilization and she can't have the son, she is going to be subjected to ongoing abuse by the partner and the family. And that doesn't necessarily mean that due to that pressure, we are going to provide her funding, but my consideration will be different here. So I will then say, and how important is it for you actually to have the reversal done and produce a son? And then second thing, have you thought about, you know, when you have the reversal sterilization, obviously there is no guarantee that you're going to have a male baby again. It may be a female girl again. So how you feel about that then? So anyway, the way the candidate went on, because they talked about, you know, the reversal and you will need to pay for it. And she said, okay, if I pay, and when he talked about the IVF options, then she asked, okay, so if we go for IVF, can we choose the gender of the baby then at that stage? Okay, so if she asked that question, then we can offer her to say yes, you can, you know, choose the gender. However, it depends again, you know, when they have fertilized, you know, those are the starting ones, whether there is any male baby starting from there. You know, there might be the females are the one which actually is going to produce the male may not be of a good quality, and there may be a risk of, you know, obviously we do know there can be some poor embryos and poor quality and that quality. So we need to give that information to her as well to help, and then again to assess. Yeah, so she will be so the purpose for me to revise this here is that always be aware of these. You know, when we use the word holistic approach, be open, be natural, okay, to think, okay, somebody's saying that, try to go that way. Don't fix to that particular template we have practiced, and we just keep going on and on and on that. Yeah, take these small little clues. There is some reason. It's very natural if somebody's saying we had a boy and that's one. Oh, right, okay, so what were you feeling at that stage? So anyway, so this was one scenario. Be aware if that scenario appears again. This is how you need to make sure there might not be anything there. That women might be happy, you know, to say as well, no, that's fine. I also wanted to have that, you know, cesarean sterilization done there because we thought our family is complete now. We did it, and then she might be happy to pay for this as well, an IVF, but there might not be anything else going on. All we still need to go is to give her that awareness to say that, you know, that you do not have to do that if you yourself don't want, and then give her the risk of, you know, the procedure as well, and then talk about repeated 3 cesarean section after that. Now, even with the IVF, the risk of placenta previa, crate or life-threatening risk will be there. So explain that as well, and then again say, so because of these serious life-threatening risks and complications, some of them, you know, associated with that all, I would really encourage you to make that decision according to what you want. Okay, it shouldn't be under the pressure of that. And if you feel so that there may be some ongoing pressure on you or anything like that, you know, you can't get help. There is a support system available for you. So encourage her to take a decision. So Sapna is asking, do we have to discuss safeguarding? That's what we are doing, darling. Sapna, by asking these questions, this is safeguarding. Okay, and obviously if she discloses then to say, yes, she feels that all that going on her and husband and partner, then obviously you forget reverse sterilization for the time being, then follow the pathway of safeguarding and start talking about the domestic abuse, give her the information about and encourage her to say, and then give a brief detail at the end, you know, after doing that. And then don't forget the women who disclose that she may not be willing to report at that stage, and even if she's willing to report at this, always make there another appointment in 2 to 3 weeks time to bring them back to check on them, how are they feeling about. And then if in the first time they didn't wanted us to report it, then at least we have the opportunity second time, because they will have 2 weeks to think about it, to reflect on that, and then take some informed decision. Okay, so the basic few, these very important fundamental points. And if you don't address them, unfortunately, they can be quite fatal for exam point of view. Okay, any question? Oh, there's a pin drop silence.
Hi, Dr. Safia. This is Rania. I was just wondering if it's allowed to do sex selection IVF in the UK. I'm not sure.
Yeah, so sex selection, there is no as such clear guideline or any protocol in place to say whether you can have the gender selection or not. However, again, if we go according to the right of autonomy of the patient, and if they have the right to actually basically to choose when, you know, sometime pre-implantation testing, genetic disorders and any risk, sometimes there might be, you know, very mild condition. If they have the right to choose and to go for termination, then why not to have the right of selecting a gender as well? So my answer will be yes. You can. We will make these arrangements and you can discuss with the fertility team. But it should be all right. There is nothing in place which says you can't. Because again, I know in certain parts of the world, because of these cultural and these influences, like they want to have the boys, and there is a pressure, society and the family pressure. In the scan, like, you know, in certain countries, I am aware that it's illegal. They don't tell you the gender of the baby, fearing that, you know, if it's a girl, the people probably will go for termination or whatever. But because the things are different here in this country, they have the autonomy. They can choose to abort if they want. They can, you know, they can reduce the cesarean section if it's really needed and let the baby die. In all those circumstances, then there is no reason why can't they choose the baby. They want to have a boy or a girl. But there is no clear guidance or anything on this one. But there is nothing against that either. So my answer will be yes, this is possible, and we will arrange your appointment with the fertility clinic beforehand. You know, where you can discuss all your concerns and what you want to do. Right.
Yeah, thank you. And just one more question about the advanced age. You mentioned the uterine artery Doppler. Do we do it routinely
In those
for?
women, I said in those women who already have pre-existing hypertension. Yeah, because they're
So
high risk
only
of
the
preeclampsia.
hypertension.
So those women, yeah.
Okay.
Okay. So any scenarios you guys have sent me now, you feel this usually is for you guys to tell me what you want to discuss in this session. So the few important ones which I thought are important, I have done them. Any other recalls you guys are aware which you find was dodgy?
Ma'am, you were telling about sickle cell something earlier.
Yeah, sensation and sickle cell disease. I think that usually appear as well. So, that is absolutely again 100% guideline though. The discussion is absolutely about the guideline. Placenta previa comes very frequently. Again, the whole guideline questions. They ask you how to diagnose, what the management, and all that stuff. PPH appears in that as well. Just all those important guidelines, really.
Ma'am, there is also one recall, which is a structured discussion of a 44-year-old lady. She presented with primary infertility, came from Ghana. Her investigations showed, ma'am, that if you want, then I can send it on the WhatsApp. This can be
Yes, send
discussed.
it on WhatsApp so we can discuss it then. Okay. So this is a scenario. So which one, Asma? Feedback to junior who attended
It's
section
11, 11 number.
Okay. Okay, so 41 years old, 1 year of primary infertility, came from Ghana, investigations here, plus MRI from our country. She had multiple fibroids, symptoms, regular periods, actually no complaint at all wherever I asked. Her work up included progesterone 37, FSH on day 3 was 21. Said the same results, semen normal, HCG2 patent. Interpret the MRI. Are you going to remove the fibroids or not? Justify. What is your plan for her? Is there any evidence that myomectomy can improve her chances of conception? And FSH is 21. Right, okay, Asma. So we're going to make you to present that. And then we're going to take things. Unless anybody else from your list, Pramila, wants to do it.
I think earlier Reena Kumari was not there. Now she has joined.
And Asma, are you aware of what was the units of this FSH 21? Is it the high FSH? What are units?
No, ma'am, I just was going through the previous recalls. This recall came in front of me, and I was thinking that if these are the LH and FSH, so, and she's probably most probably going towards premature ovarian insufficiency. So how can we discuss the role of myomectomy in that case?
Okay. Who wants to do it then, please?
Reena Kumari, are you there? No, I think she might be on mute. Whoever bought this scenario, let her do it.
Okay, Asma. You do that.
Ma'am, I can start.
Yes.
Okay. So this is a case of a lady who is presented to us with the primary infertility. In the background information, she is 45 years of age, and her MRI reports are with me that shows that she has multiple fibroids. I would and her seems to be she doesn't seem to have any complaints of any urinary or bowel symptoms, and and she has regular periods. So I would like to have further information regarding this patient in the form of her history, so that I can know the regularity of the periods, how long she's having the periods, because most of the women who has the fibroids in their scans are most likely to have heavy menstrual bleeding. So this question is going to give me a more idea regarding the heavy menstrual history regarding the heavy menstrual bleeding. And then I would need to know that is there any significant history related to postcoital bleeding, intramenostral bleeding, or dyspareunia, in order to rule out some other cases, in order to rule out the endometriosis and cervicitis, or any implications of this as she is presenting with the primary infertility. Then my next question would be asking her regarding the to exclude for the pelvic inflammatory diseases. So I would like to know regarding what is the is there any vaginal discharge, any pain lower abdomen, and bilateral tenderness, pain lower abdomen. And then I would like to have more information regarding the pressure symptoms, as the fibroids are present, regarding any urinary or bowel symptoms. And then I would need to know that is there any other previous history of surgery in the past. This can give me an implication of having scars in the primary infertility. And then I would also like to know about medical conditions of that lady, because she's already 44 years of age. So I will need information regarding if she's having any hypertension or diabetes, or any other medical condition for which she's been following to the GP, any other history of taking any drugs right at this moment. And because if she might be taking some NSAIDs, that might be causing some problem with the ovulation. And then I need to know about allergies to any kind of drugs. So I need to know about whether she's smoking or not, because this can also give me an idea that if she's smoking, then referring her for the NHS funding program for IVF can make her a little bit unfit regarding this. I need to know information regarding her alcohol and recreational drugs if she's taking, and then I need to know about her further information regarding her husband or the partner she's been living with. What is the status of the semen? What investigations the partner has gone through, and how long she's been with this partner, and whether the partner has any children before. In the previous relationship, and then any other problems with the partner, like any medical condition for which he has been following to the GP, any possibility of having diabetes or any other exposure to the radiation, and the smoking status of the partner, and also the possibility of taking any recreational drugs. I need to know that how the sexual activity, sexual relations of both the partner is it comfortable, or and also to know about the frequency of both having coitus of both partners.
So I can give that information here. So they both are fit and healthy, no problems with the ejaculation or erection, anything. They are regular with the coitus as well. And these are the investigation results you have. So how would you approach to the management?
I would be having as this workup is with me and showing the progesterone is 37, FSH on day 3 is 21. So I would obviously be asking for repeat FSH level, and I need so that we can see that whether she's progressing towards a premature ovarian insufficiency or not. This has to be repeated after 6 weeks, and I need to have more knowledge regarding LH levels also. and if I can also have the serum AMH because she's 44 years of age, so I need to know about the ovarian result. As I have the serum is normal, and HSG has also been provided to me with the normal results. So that means she's patent tubes are so in this case I. I should have done examination in the previous, telling about the history, because I need to know about how much the size of the uterus is, and is this regular or irregular, and what are the actual size of the uterus, and whether the fibroids are separately felt from the uterus, because this is also going to give me implications regarding that the fibroid is subserosal or intramural or it's submucosal. I would also like to have this information in the form of scan, ultrasound, so that I can know the location of the fibroid. Is there any other ultrasound information available with me?
Yes, so she has so she has multiple fibroids. There are myometrial and some mucus fibroids, and one, there is some endometrial protrusion as well.
So in that case, as MRI would also be giving me more detailed information regarding the location of the fibroid plus this TVS and abdominal scan. So in that case, as her tube test is coming normal, and on her day 2 repeat test, FSH is still coming 21. So I would like to have the LH and AMH results also to know, and if everything is normal, then we can discuss about the probability of removal of these fibroids, because sometimes these if there are submucosal fibroid present in the posterior wall of the uterus, then there are probability of having increased chances of miscarriages, but there are no evidence has shown that there is going to be any problem in conception in the presence of fibroid. So if the fibroid is present in the posterior wall and it is submucosal, then we can discuss about the implication of this in the pregnancy. If this, as she's been unable to conceive, so she will be referred to the fertility clinic after fulfilling the requirement of the IVF clinic, and then she will be given the full one cycle in which a single embryo transfer will be planned for her, provided that FSH and LH are in the normal range and AMH levels are normal.
Okay, I'm going to interrupt you here now then. So you wanted to do her anti-malarial hormone test. So the result is 0.5 nanogram per ml.
So that shows that she's not having any ovarian reserve. That is very poor, and we cannot plan for any of the pregnancy. So she's moving towards the premature ovarian insufficiency. So I need to have, is there any repeat test of LH or FSH available for me?
No, you can take the same again. The FSH again has come back about 23.
So she has she is diagnosed to have premature ovarian failure. So we need to tell this news to the patient in a very sensitive manner, so that she should be told that there are no chances of conception. Still, in most of the cases, 10% of the women can have conception, but for this they can. But this cannot be predicted, and they can have other option of oocyte donation, and also they can go for the adoption.
So are you going to offer this woman myomectomy?
It depends upon the location of the fibroid. So if it is intramural, then there are certain studies that have shown that it doesn't have any effect on the chances of conception, and so this implication would have to be discussed with the consultant, and will have to tell the patient regarding that, as there is no role of taking out the fibroid unless it is submucosal. We won't be offering in case of the intramural, but if this is submucosal, then we will be offering her.
Okay, thank you. Right, interesting case, really. Yeah, you did include most of the important points. Rani is asking if there is a talk article on this one as well.
No, ma'am, there is no talk article I could find. There was one article dedicated fibroid in pregnancy.
Yes. There's a fibroid in pregnancy talk article there, but not particularly to fix this scenario as such. Okay, so what basically is happening? She's a 44 years old woman with a primary infertility, and she has multiple fibroids, and then she has a high FSH going towards ovarian insufficiency. Getting that information was fine, just the routine information you will do for any primary infertility patients. Just ask whether the most important, another important aspect here is these fibroids, we are not going to consider what we're going to do fibroids only for fertility point of view. Okay, so that the other important aspect you must keep in mind is she symptomatic for the fibroids, right? So her period frequency, her amount of bleeding, what is her hemoglobin status, dysmenorrhea, and any pressure symptom of these fibroids, right? So if she actually is bleeding quite heavy and she has pressure symptoms particularly as well, then you need to consider the management of fibroids as well, starting from the Marina or progesterone, but obviously she wouldn't like to go on Marina and stuff for a long period. She's 44 already, wanting to get pregnant. In that case, myomectomy can be considered, yeah? So we can see it may not have, and then the other aspect we need to relate that the fibroid is that if she is actually having the ovarian reserve, insufficient ovarian reserve, so yes, you will go for anti-Malarial hormone testing levels, and the normal range is usually 1 to 4 for the good pregnancy outcome. To go 1, obviously the chance is significantly reduced. They go below, I mean, still there can't be a chance of about 3 to 4%. The 10% were very high, Asma. I usually recommend not to play with the numbers in the exam unless in structured discussion you are actually pushed to say that, and then you're not sure it's safe to say, or you can say that the spontaneous rate of pregnancy is extremely low. I cannot remember it at the moment, but I can check. And then I can tell. Better is this to say, yeah, because 10% is very good and promising chance this woman can sit on these then to wait for spontaneous labor, spontaneous conception to happen. So yeah, so you're going to basically, yes, the information will be routine about the fibroid symptoms, keep in your mind, and the fertility history, right? What GP has done till so far, again, for the management plan and for the fertility, what they have, semen analysis. Any problems with that? Yeah, if the semen analysis is okay, I won't go into much detail about the medical history of the partner and stuff. As long as those investigations are normal and fine, the BMI of the woman will matter here a lot. Any coexisting medical condition, it becomes the 3 main points. Okay, fibroid itself, ovarian insufficiency, and then she's like 45 beyond, we call it is very advanced, she's 44. We need to keep that in mind as well. Does she has pre-existing medical conditions? What is her BMI? And then we need to take these 3 aspects together before we decide and make the management plan. Okay, so regarding that, then you need to say if she's symptomatic for fibroids and she has pressure symptoms, then obviously the options needs to be discussed with her for the management of her symptoms for fibroid. Which obviously includes, starting from combined pair or going to the Marina and the myomectomy, and keeping in view that she wants to get pregnant as well. Myomectomy obviously can be considered, can be the option for her for symptomatic relief. However, from her fertility point of view, so if she's not symptomatic or she's not like having much pressure, then she doesn't want to have myomectomy only for the relief of her symptoms. She particularly want to consider that for her, the treatment of infertility point of view. Then obviously, again, we need to take that discussion with her. So with so low reserves of her ovarian reserve, she has only, obviously, if the level come back at 0.5, there's only 3 to 4% chances of spontaneous. However, we can still, we can still consider if it was causing. I said there were mucus, submucous fibroid, couple of submucous fibroid which are causing distortion of the cavity. We can offer her to have the myomectomy and then go for IVF. She can use donor eggs. Okay, so the answer is not straightforward that we're not going to offer her. It needs to have a little bit complex discussion and options discussion with her. So we can offer her, if she even have a low ovarian reserve, they can use the donor egg, donor ovum, and that can actually again give them the advantage to reduce the risk of chromosomal abnormalities, the risk of Down syndrome in the baby because of the age factor. So they can have the IVF. However, IVF is not funded for 44 years of age, and then she already has some other factors which can compromise her chances of successful IVF cycle. So that will need to be arranged by private. She will need to pay for that. Yeah, this is not going to, because there are two factors here: age as well as very low chances of successful IVF. So as long as they are happy and they're ready to pay for their IVF, then you can consider for a removal of the fibroid as well, so they can have the her own retriever of eggs. But preferably we will encourage, or we will at least recommend them to use donor ovum from comparatively young patient client to use, and then have the IVF treatment and the management. Okay, so this is how this discussion should take place.
Okay, thank you, ma'am.
Somebody asked surrogacy. So she has a very low ovarian reserve already, and then with a low ovarian reserve, we do understand the number of ova. Even if we can retrieve the ovum, the quality of that ovum and the successful fertilization are very low. So somebody asking, you can try with low quality of ovum and fertilize, and then go for surrogacy, and you can do that. It's better probably to go for the adoption. And surrogacy is not as such something, because we can remove the fibroid and give her the chances. So I won't say she hasn't had something that level wrong, or abnormality or distortion of the uterine cavity to that level where we actually can't address, and we are offering her surrogacy. So I won't be discussing for surrogacy for her. I will be talking about, first you need to tell there is a small chance, that she can't have a spontaneous, only 3 to 4%, 3 to 4 out of 100 in her circumstances of chances of have a delivery. And if she has some mucus fibroids distorting the the cavity, then we can discuss the removal of those fibroids to give her that they can increase the chances of her successful conception. However, given that her ovarian reserve is very low, and then I'm going to inform that as well, that it's not only that the number of eggs in her or the ova, because the discussion, you can take the clinical language here, the number of ova is reduced, it's all the quality of ovum is also reduced. So the chances of successful pregnancy in her circumstances are very, very low. So she can consider IVF and removal of the fibroid, and then followed by IVF. And in IVF as well, she can consider to use the donor sperm to avoid the complications of, number one, obviously, the quality of the ovum, and also to reduce the risk of her genetic disorders, chromosomal abnormalities, and high risk of that one. And don't forget the other one, holistic approach as well. If she has any other ongoing medical conditions, they need to be controlled and stabilized and optimized before we go ahead with that. Okay. Other investigation other than these hormonal profile, I would ask from this examiner will be to give me her hemoglobin levels and iron serum ferritin level if they are available, because they will also indirectly give me an idea how symptomatic her fibroids are. Okay, and the size of the fibroids as well. And then when we're talking about the myomectomy, then obviously we need to talk to her about the risks and the complications associated with the myomectomy as well. If they are large fibroids or multiple fibroids, then obviously when we're removing them, there will be a great risk of hemorrhage. And then, as we say, we will try to obviously control that complication, replace it. But however, there will be a risk that we may end up doing hysterectomy. So this is more about that discussion, basically to give her informed choice. So it's not straightforward to see whether we will do a myomectomy or not in her case. Okay. So is there an evidence myomectomy can improve her chances of conception? That just like that same thing you need to say. There are some mucuses submucous fibroids and this causing the distortion, then yes, the evidence suggests removal of these fibroids and the myomectomy increases the chances of conception as well as chances of successful birth with these women.
Dr. Sophia, after
Yeah.
myomectomy, can we will give her 6 months or 1 year gap, or no need of that?
That again, it itself goes into very complex discussion. I wouldn't touch that at this stage because in this we won't have the time.
We will not, in this we will not touch. Okay.
I wouldn't talk about that unless I am asked by the examiner particularly to talk about that you remove the fibroid, how long you're going to wait and all that stuff. Because then I need to keep in then if they happen again, keep it simple, just go on that route. Say yes, or if that is, that will again also depend on the size of the fibroid. And then if we are doing like, she's already, very low ovarian reserves, by that she might go into complete premature ovarian failure. Yeah. So,
Yeah.
but that you just keep a natural discussion. If they ask, just go on that route to say if that happened, then these are these are the few consequences. Then we will need to discuss with her as well. So instead of that, she might write at this stage, and if they're not causing the distortion of the cavity, then we can discuss with her. The conception, the fibroids are not affecting her rate, the chances of conception to get pregnant. However, if they're multiple and significantly large size fibroids, they can then cause the complications for the ongoing pregnancy. Yeah, so then we need to talk about all those risks, which because of the fibroid in pregnancy can be, right? So starting from degeneration, risk of miscarriage, then risk of premature labor, IUGR, placental abruption, all those risks. So it depends which way your examiner take your discussion. But overall scenario, seeing the scenario, the first half, which I have explained to you, that should be enough to answer. And then obviously just go according to. So that discussion needs to take place with her. Anything else? Thank you, Asma. That was really good question you brought to our attention. Very nice, yeah.
And there is one more scenario of risk management of the shoulder dystocia. So in that cases where any scenario is in front of you and they're telling you to speak and how are you going to do the risk management. So what is the template we should follow? I'm unable to find the scenario right at this moment, but usually in the exams.
Sorry, so say again, what is the, how does it appear?
Usually, ma'am, it's most of the time the scenario is given that there has shoulder dystocia of the has occurred, or the doses of low molecular weight has been missed, and the patient has presented with peak pulmonary embolism now. So now you have to do the incident reporting and discuss about the risk management, how you should do it, and how you have to arrange for the feedback session. So what is the template we should follow only to discuss with the examiner in 10 minutes?
Yeah, okay. So this one, the missing that dose, and then the woman has a PE, we just have done, I don't know, maybe you have missed the first part of the session. So I've just discussed that. So you need to include those points. And then the feedback, is if that is a feedback to give to the trainee, that will come as a reflection. So you will encourage, if it's somebody else other than you, then you will say, the reflection on this incidence. You will encourage that trainee or the nurse to do the reflection on that incidence, and then follow those steps of reflection, those 4 steps. Yeah, what happened, how that could be improved, what is learned, and how you're going to apply that into your future practice. When we said like, so there will be risk incidence and risk analysis and the management. So just listen that part. I have just answered that one already.
Oh.
Anything else? So we talk about, so your feedback to your junior, you have attended, you got a good store of questions, Asma. Why you haven't shared with us before? So that was just similar thing we talked the day as well about the operation notes, yeah, where it says like she has written this and she has written some and she hasn't written some of them. So GP for contraception. So we have discussed that, yeah? So follow that template, operation notes and the discharge summary. Anything else before I close?
In the WhatsApp group, Dr. Reena Day has put a scenario of postmenopausal patient who had TAH for heavy menstrual bleeding, now has come with postmenopausal ovarian cyst with increased CA 125. That was put on 5th September. CA 125. No family history of malignancy. She wants to know the plan of management, why chance of malignancy when she has no addiction and no family history of malignancy.
Okay. I need to go on that again. So sorry, what is that scenario? She is
Dr. Reena, are you there? Can you tell?
Yes, I'm
but
here.
that posted in the group, in July group?
Yes, ma'am,
Yes,
I
yes,
posted
ma'am.
you personally as well.
On 5th September, she has posted. What was the?
Can I tell you the scenario?
Ma'am, I have posted one more scenario which came into my exam. If somebody
This
wants to
one.
discuss.
Okay, let's see Reena's scenario first and then we will come to yours, Asma. That's the one, yeah? Okay.
Yes, ma'am.
Yes, ma'am.
So postmenopausal had total abdominal hysterectomy for heavy bleeding. And what? Okay, so she has now come with postmenopausal ovarian cyst with increased CA 1 to 5, no family history of malignancy. She wants to know the plan of management. Why chance of malignancy when she has no addiction? What that mean, addiction?
She in the exam scenario, she said that I have no addiction, no family history of malignancy. Then why this has happened to me? So this was what the
Okay.
doctor was going on saying.
Okay, right. Okay. So, right, so it's a very simple, straightforward, just like as we consult some women with the raised CA1 to 5 and complex cyst. So we need to have the findings of that cyst as well. So I guess that must be complex cyst with raised with coming malignancy risk index quite high for malignancy, yeah? And when we explain that when, you have, so the way you will explain, you will say after obviously the, take the information. So I hope that obviously the scan findings will be given. So take the normal history as you will take. So tell me more about your, whatever is written in the scenario she presented with abdominal pain or see. So tell me more about your pain or all that, and then let her give the history. In the history, obviously, at this stage, you need to ask about, then as we said, follow that template, ask about the signs and symptoms of any malignancy she has after her presenting complaint detail. And then family history of any, the cancers, clearly asking, don't just simply ask, is there any family history of any cancer or any concern? Clearly, family history of any breast, lining of the womb, ovary, neck of the womb, or the bowel cancer. BMI, as you will ask about the parity, and then if she has taken HRT, or not, and then you start obviously talking by saying, okay, so your doctor or whoever has done this scan, we had the scan done, and the scan shows that you do have a cyst. Obviously, you need to ask, okay, so there were heavy menstrual bleeding, hysterectomy. So then you will say to her, okay, so the scan shows you got a cyst on your ovary. Cyst is a water-filled sac, or a clear fluid-filled sac, and they can, come and go in the ovaries. However, if they go beyond certain size, and also if they have some certain characteristics, then we need to, remove them. So your scan shows you have that cyst, and that cyst actually do have, and I hope they would have given some features. You can say, you know, that, but that does have some solid areas as well, and that does have some partitions as well. And when the cyst shows this type of appearance, then we like to do some further test and make an idea to exclude. Okay, the word we will use, exclude, to exclude the presence of cancer in the cyst, because sometimes the cancer of the ovary can also present, you know, that can appear like this on the ultrasound scan. So to get further information, then we do check a certain chemical, we call it CA125. We measure the level of that certain chemical in your body. This particular chemical is produced in different conditions in the body. It can be, you know, produced and raised if there is some inflammation and infection in the body. And I won't talk about endometriosis in this moment, she's postmenopausal. And it is also produced by certain cancers of the ovary, and that's the reason we do check it. And then once we have the results of this level, then we do a certain calculation to assess the risk of cancer in your circumstances. So keeping in view the appearance of your cyst and also this this CA125, I'm afraid that has come back suggesting that there is significantly high risk that this cyst can be a cancer, right? So she will be shocked first, why and how, and do I have a cancer? No, you don't have a cancer. But all the information we get from this results we have at the moment with us, that suggests that you have a high risk of cancer. Okay, so for that now we need to do, you know, I need to discuss with my consultant. With the same template, we need to arrange one more specialist scan called the CT scan. That will give us more detailed information about the nature of that cyst, and also that will give us information whether, if in case if you know, this disease is only confined to this one ovary, or it involves the other ovary as well and other parts of the body, particularly your bowels and the lining of your bowels as well. So we will need to do that test, and then we're going to discuss that in our team of doctors, different specialists, which will involve the gynae cancer doctors as well, the radiologist who has given us the scan report, and also the, you know, the doctors who do the examination once we will remove this cyst, for that cyst to exclude the presence of cancer. That's called multidisciplinary or MDT. So that's the routine template you will start talking. Now, in between, if she asks you why I am at high risk of cancer, there's no family history, or whatever she say, I have no addiction, or no, I have not done anything wrong and all that stuff, then you just simply need to say that you are right. Yes, in the people, there are certain risk factors. We say that those people can be at high risk of getting, their risk can be higher than the normal average population. Okay, so if somebody has a family history of cancer of the ovary, and particularly if there's the type of the cancer we run in the family, we will tell to that woman that their risk is higher as compared to the average population. However, there is, you know, a risk of, you know, the cancer this much, you know, risk. If you don't know the numbers, you can have a look and tell you exactly. So obviously there is some generalized risk of cancer overall in the population without having any additional risk factors. All right. So and obviously if she's getting stressed, I will say, I can see you are very concerned and you're very stressed and anxious after this news. However, I will encourage you to stay positive at this stage, because although it says it is high risk, the chances are more, but obviously there are still chances. It may not be cancer. All right. But so what we need to do, you just can tell the standard treatment. So, you know, you say, although we will be able to tell you the exact management plan after the discussion in our multidisciplinary team, I can just give you an idea. The standard treatment usually is then to remove both ovaries. And then if we, you know, that specialist can indicate that the part of the bowel or the covering of the bowel is involved as well, then we may decide to, you know, remove that or a part of that as well. However, I will be able to give you details at that stage once we have all those scan report details with us. So the standard is, yes, we remove that with the operation, and then after that, that can be followed by some further treatment with a specific radiation, we call it radiotherapy, or with the specific cancer medication called chemotherapy that can be given. Okay, it is too soon to actually talk about all these in detail at this stage, because it's not like, okay, there is a high chance that it may be cancer. There is a small chance as well that it may not be cancer. Okay, so reassure her about that as well. And then obviously you say, like, I will give you the detailed information about this type of appearance of the cyst, you know, we call a complex, and what exactly these raised levels of CA125 means. I will give you the information about that as well. So we're gonna have that, you know, the team meeting, MDT and everything within 2 weeks, and then I will arrange your next appointment to come down. And then same way, encourage her, you can bring your partner and any other family member or friend with you for the support in that meeting if you find it may be stressful for you. All right. Rena.
Ma'am,
Hello, Rena.
yes, ma'am. Ma'am, if it's
Was
a
there
simple
something
cyst,
which appeared in your exam, this station?
yes, ma'am. If it's a simple cyst, now I can, it just suddenly it came to my mind that it was a simple cyst look-wise. It was not a complex cyst in the scan. However, the CA25 was raised. So after calculating, it was not going beyond 200. So at that point of time, what do we say?
Okay. So if that happens, then again, we start in the same way by saying the cyst, these are just a water sac, and then we do this hormone, which I talk about, this particular chemical, we call it CA125. We have done that, and the level from the result of these two, we do there is a specific way we do the calculation to assess the risk of presence of cancer in that cyst. So after these, you know, the investigation, the calculations, your risk for cancer is very low. However, at least you know, because of the size, if it is obviously beyond 5 centimeters, then you need to say that this size is this 5 centimeter is. I'm going to discuss with my consultant, and then obviously we don't need to take that to MTT here. The simple will be that after discussion with my consultant, we will then arrange for this to be removed along with the ovary, and obviously the other ovary will be taken out as well, just to remove the, you will say, to reduce the risk of any other cyst in other ovary, heated cyst in the same ovary, you know, because the function of the ovaries has reduced already, the amount of the amount which they were producing. So we can actually remove them to reduce the further risk of any, you know, cyst or any cancer in the future in these ovaries. So how you feel about it? So that will be very simple. And obviously, if it's less than 5 centimeters, then according to guideline, you just need to follow to say, you know, and the size is very small. So we can just leave it, and we can then repeat your scan after so much time period to see and repeat to this one as well. However, then you will need to give her the instructions for red flag sign symptoms, that if you start feeling bloated, or you start feeling any pain or any irregular bleeding, or any bleeding, vaginal bleeding, you start feeling any loss of appetite or your weight reduction, in that case, you will need to immediately contact us, so we can repeat your scan and also this test, because, you know, sometimes they can be a very small, extremely small risk that even these simple cyst can proceed. You know, there can be some cancerous changes in them as well. Does that answer, Rena, your question?
Yes, thank you, ma'am. And do we need to tell them anything regarding the histopathology, that we can be very sure after the histopathology has been done?
Yeah, so we will explain. We are going to send, yes. So we will remove this cyst, and then we will send this for the detailed examination regarding histopathology, just to be on the safer side to exclude the presence of any cancer. That obviously is a fixed template. Obviously, if you're removing, you have to send them histopathology. So this is, you can explain her.
Thank you, ma'am.
But if then given the scenario, let's make our life complicated. So if it's a simple cyst with a low CA125 and there is a strong family history of, you know, the cancer, like she otherwise have a high risk family history or some member of the cancer, then even if it is like, say, 5 centimeter or 4 centimeter cyst, I will then discuss with her the option even to remove on that size as well, just to say, although the risk is very small, and the standard practice and recommendation is that we can leave this cyst alone and repeat your scan after this much time with this blood result as well. However, if you feel, you know, anxious because of given that history in your family, we can remove that cyst for you and send it for the detailed examination. Okay, so in that woman you can offer, and that's like the guidelines, we can deviate sometime a little bit, according to the individual circumstances of that particular patient. So if somebody is really anxious because of the family history, low malignancy index, but very anxious, I can't discuss unless it's very small, like 1 to 2 centimeter cyst, and she has no sinus symptoms. Then I will encourage. But if she still is very anxious to say no, remove it, then I will say, okay, we'll discuss with my consultant. I mean, it's very small cyst anyway, so we'll see if we can, remove it for the peace of mind.
If it's a postmenopausal cyst, then if it is beyond 1 centimeter, don't we need to investigate it?
So for the menopausal cyst and stuff, any woman who present with the symptoms where we could think of any ovarian cyst or anything, CA125 is already ordered at the time when the scan is booked. So scan and CA125 will be booked together anyway. So you will have CA125 result in your hand already. If not, then you will still do CA125. All right. Somebody's asking, will we do the cystectomy only? If it's a postmenopausal woman, or if there's a woman like about 47, 48 years age, well, postmenopausal, certainly bilateral oophorectomy, oophorectomy. But for women even at 47, 48, if we have to do cystectomy, we will be offering her bilateral oophorectomy. Okay. Okay, so
is there any
question,
FGM scenario, ma'am?
Sorry?
Is there any scenario on FGM?
I don't have FGM scenario, but if one of you guys have, we can discuss that.
Anybody has got any scenarios? Have you seen like that?
There can be discussion, structured discussion on FGM. I don't feel there will be role player on that. There can be some discussion, structured discussion, and that again should be just the points of your guideline. If that's the one you have sent us now, Asma?
Yes, ma'am, that's an easy station, but I just wanted to bring a notice that it came in my exam.
It's 14, number 14, yeah?
Yeah.
Okay, so maybe 35 weeks of pregnancy, para 1+1. First was spontaneous miscarriage at 7 weeks. Second was pregnancy complicated by gestation to blastic disease. Managed with, gestational diabetes, sorry. Managed with metformin, vaginal delivery 30, no case of stage 2 CKD. Glomerulonephritis, pregnant 9 weeks. In the board, there was a page with her recent result, full blood count normal, eGFR 79. Antenatal clinic, she was showing current drugs, aspirin, multivitamins, also telling she is on regular renal follow-up. Recent scan normal with date, but she denied screening. Screening of what, Asma? Which screening was she denying?
Ma'am, I think the first trimester screening she denied.
So she didn't want to have any blood tests, HIV,
Yeah.
syphilis, those stuff?
No, ma'am. This was like 11 to 13 weeks that we've offered them for Down syndrome screening.
Combined test.
Yeah, combined test.
Okay. How old was she?
She was 32 or 35.
Okay. So again, same standard technique. First of all, ask her about the concerns. Why she particularly doesn't want to have that screening done. And then explain what that screening is. That it's non-invasive, it's not going to cause any harm or damage to the baby. That scan will be done at that as a dating scan. And there will be some additional information about the baby they will observe, and then this is going to be a blood test, so that does not cause any harm to the baby, because it might be. So ask the concerns first. What are her concerns? So then it again depends the rest of the discussion what she says. If she says, say for example,
No, ma'am, it was sorry to interrupt, ma'am. It was a structured discussion. So examiner was like bee on the wall. He was not telling me anything, and this was written. All the course 4 questions were written there.
And the screening, when you say was declining, it was down screening she's declining, yeah?
No, ma'am, he didn't give us any clue that why she was. Yeah, ma'am, that was written that she was declining the screening, Down
Down
syndrome
syndrome
screening.
screening. Asma,
Yeah.
can you be a bit specific? Was she declining Down syndrome screening?
Yes, ma'am.
Okay. So then you can obviously just consider those factors. Just simply say, you just start by saying that she's the first. Obviously, you can summarize the scenario by saying, I have noted, she's this and she has a stage 2 CKD, and so she will be high risk pregnancy from kidney disease. So you need to just keep that in mind as well, that we need to have her recent test available, and if she was gestation diabetes as well, then did she have any diabetes? So she needs that screening basically. So you need to do her screening and then repeat at 26 weeks. She will be high risk preeclampsia and stuff. So keep that on one side. The routine, just like the scenario we have done already, renal disease scenario, yeah, those risks will be there. Now regarding the screening, then simply you can start by saying, okay, so first of all, I would like to explore her concerns, why she doesn't want to have this Down syndrome screening, and then you can continue again, because if you say I want to explore the concerns, you just need to speak as well what concerns you think she could have. So is she worried about that this test may be invasive? Is the reason that she actually doesn't know the details of the screening test, and that's why she's scared to have that test? She might be having that fear that it might cause miscarriage or any problems for the baby or any harm to her pregnancy. So if that's the case, then obviously we need to reassure her, explain the test and tell it's non-invasive and there is no harm for that. The second concern can be, is she like worried already that she feels she can she's at high risk that her baby may be affected by the Down syndrome? Is there any family history, of any child already of Down syndrome? So you need to do that calculation, risk calculation. Does she have any risk factors for being higher risk for Down syndrome? And the first baby, she has one alive, yeah? So just get that information as well. Is the first baby, did she have the Down screening for that baby, or is the baby affected with the Downs? So there might be something coming up. So one possible reason can be that they might have a Down affected baby already, or there is a family history and she feels she's at a higher risk and she doesn't want to know, right? So if she doesn't want to know, as long as if she has you need to, then we will give her the information by saying, okay, so that there are these tests available we can do, and that only tells about the risk, that she's high risk or low risk for that. That doesn't tell about the diagnosis. And if that come and anybody wants to, so you will tell about the detail of the testing first. And if it come back as a high risk, then we can offer them this test to do the the invasive testing, which can be CVS, chronic villus sampling at this stage, from 11 to 14 weeks, or she can have amniocentesis. I will also inform her about the risk of the miscarriage, and then I will encourage her to take her the same thinking about what she wants to do with that result. The same thing I've explained already. If it come back as a Down syndrome, that confirms Down baby is affected, would she still continue with the pregnancy, or she's considering to have termination? Because it's not uncommon. It might be very simple to say, that she doesn't want to go for termination anyway. And then some of them say, then what's the purpose of doing the screening? It doesn't affect my decision anyway. So then we can encourage. There's sometimes, that it can help if you know already whether the baby is affected or not. And if the baby is affected, that can give the time to you to be prepared and get more information about what to expect if the babies are affected, what complications they can be, how we will monitor and look after her pregnancy then, and then she may be more prepared and have the support in place to look after a baby affected with the Down syndrome. So we can tell her the benefit of that, and then if she still doesn't want to have, that's okay. But I guess probably it will be, instead of screening, it might be she declines invasive testing. Asma, what do you think?
Ma'am, there was only written that the patient declined screening and there was no other line mentioned.
Okay, that's fine. Then in that case, we can just progress on that.
Assalamu
And,
alaikum,
I will counsel her, tell her about that, and then ask. And as long as you will say that I can assess she's competent to give the consent, then obviously yes, that's her right to. And if she doesn't want to, after giving the information, but you must, just like as HIV testing, that woman was refusing. So ask the concerns, ask why you don't want to. The possible causes, you can talk yourself. If examiner is not giving any answer to you, then these can be possible reasons. and then you can tell about the benefit of doing that test, how that can help. Actually, obviously, Down syndrome is something we obviously can't do anything to prevent, it from happening, but she can have that information, and then she can have that all support and plan in place to look after that baby. It will be more prepared instead of having that as a sudden, the shocking news. And that it also, if she's already then concerned and worried that the baby, she is at high risk, so the baby might be affected. If she does the test and it comes back that the baby is actually not affected with Down syndrome, that will alleviate her anxiety. There will be no more anxiety and concern, and she won't be worried for the rest of the pregnancy. She can enjoy her pregnancy, and she will be, she will be ready to welcome her healthy baby. So you will give some incentives, what it can be for having the test, explain the test, and that's it. After that, it's her, any other investigations you want to do, what complications to her and to baby you expect. So that will be talking about basically her renal, all that, just briefly and quickly you can talk about the complications because of the renal disease. It can get, it can progress during that as well. So renal physician, MDT team approach. You need to have the recent renal investigations for her. She's at high risk of preeclampsia, IUGR, preterm labor because of this. And then, if she's on any medication, look at that. Does that medication have any effect? And then you will tell the woman about blood pressure monitoring and urine protein every time. And then, then to tell her about the signs and symptoms of preeclampsia as well. She's had been started aspirin already, so that's fine. Fetal complication risk of IUGR, so you will be doing those scans from 26 weeks. You should be able to have a vaginal birth, as we said, like unless there's any other indication for cesarean section. And yeah, monitoring by the renal physician as well.
Assalamu alaikum, Dr. Safia. It was my question. It was my question in exam as well, and as you rightly told, that we have to tell the examiner about these 2 points, that what was the indication why she is refusing for screening. I would like to explore her concerns, and after listening to these 2 points, he just kept quiet. He said it's okay, now move on to the next question. So he did not ask me further detail about this. Yes.
All right. Okay. So then they wanted mainly you to talk about the renal disease and pregnancy.
Yes,
but
exactly.
Yes, you can talk a couple of these things, you can include by saying like, now we'll explore her concerns, why she particularly doesn't want to have this test done. And then you can just add these couple of points, that there may be, if there are some risk factor that she feels she's already high risk, she classify into high risk for Down syndrome. So maybe that she's worried and frightened to know about the Down's baby. And then you can explain this is non-invasive test, it's not going to increase these risks, and this is the benefit. And then offer her if she wants to, then we will do. If not, then it's okay. Right. No, you all are bringing these questions. Throughout the course, I have been asking you all to give me questions if you have. But anyway, it's still good. Right. So next, any other similar recall? Anyone, if you can think of your previous experience or from your friend's experience, we should think we could discuss today. So that was yours, you sent me, okay? Anything else? No?
No,
Right,
thank you so much.
We close it here then. So obviously your group is still open. Ask me anything. Now, all those who have actually got the date for this exam, please put your full energies into it. Try to take time off from your work and really sit down, make your own small bullet points of your summaries, okay? It's always difficult when you're reading somebody else's note. I know there is a lot out there, in different groups, summaries of these and stuff, but when actually you're reading somebody else's notes, it doesn't retain in your mind in that way. Just keep simply, write your own bullet points for your own revision. Literally small points, and that will actually, when you write down, you are actually remembering them as well, memorizing them as well. That gets stored into your memory then. So that the last minute, flashcards, we call it, you can just quickly have a look through them. The last 3 weeks, particularly, I will, at the 4 weeks, I will literally please request you all who are appearing and who have, obviously I'm talking to who have taken this course, do listen the recording. And the recording at that stage, the way to listen will be, open the module, look at the question, what that is, and then don't listen the part of that where the candidate is playing. No, skip that 12 minutes, 2 minutes of preparation and 10 minutes of the candidate. Skip those 12 minutes and just listen the summary where I'm telling the model answer. And then go to the next one. Yeah, and then give yourself a couple of minutes to reflect on that as well. Yes, these are the points. This is I'm going to do. Just kind of again on a paper, write down as a bullet points. Yes, these are the points. That is called conscious storage of memory. Okay, because now these obviously the situation has come. It's so difficult even to get space into the exam. Okay, so if you have got the space this time, then make a full effort to pass it. And the only reason why I'm saying is, unfortunately, in the past this has happened. People have taken my course, they have spent so much money on that, but then unfortunately towards the end they didn't revise through it. They were doing, you know, some of them were doing even one-to-one, and when I was taking their, and they kept their one-to-one for the last minute as well. And when I was taking the one-to-one, I could clearly tell they have not, because in between they have then gathered so much other things in their mind, and unfortunately they couldn't then obviously be successful. And that hurts me as well, you know, after spending so much money, stress you do, and then you, so trust in your Lord and trust in yourself. And then after that, please trust on my course and these ones. If you will repeat the revise them in last 3-4 weeks, there's no way you can't pass the exam. Okay girls, good luck. I'm still there. I'm not going to say goodbye because it's not a goodbye. You can obviously always approach me through the WhatsApp group.
Ma'am, what should we do? Those who didn't get the exam slot.
Pramila, so what should you be doing? So the next course will be starting again immediately after this exam. Okay, so we will have the recalls from all these people who are preparing. They will be added up into next course, and you all will be listener over there, and then continue your own discussions as well in the group. I will answer them.
Okay, ma'am. Thank you.
And stay in touch with these girls. So the people who are appearing this exam, you please do not share your recalls after the end of the day. Okay, you can share with me. I'm not going to share with anybody else, but don't chat to other candidates and stuff. It's unlawful. Okay, and it's not fair with you guys as well. Okay, so don't give those details to anybody. But after the exam, write them down though. Try to remember what the pro players were saying, what the examiners were particularly asking on the very next day. And then once the exam is over, the last day, that day, please give those stations to us, to me, to us, to, you know, wherever you want to give. That does help, just the way as you guys are getting benefit from other people who gave their recalls, the same way others can help. And if God forbid you don't pass, then obviously that's going to help you as well. So, okay, good luck to all of you. Please eat well, drink well, sleep well, a little bit of regular walk every day in fresh air to keep your stress levels under control. Trust in yourself on that day. Try to imagine as much possibly as you can, thinking I'm sitting in my clinic and in my labor room. If there's some scenario appear, you don't know at all what's happening, what is that condition they have written, it's okay. Just simply, you know, there is still some generalized template you can still follow if it's a pregnant woman, about all other history taking, VTE assist, mental health training we're doing. And then very simple, start by asking her, you know, would you like to tell me more about your condition? And there you go, she gives you the details of the condition, and you will get an idea, some idea what to do. And it's absolutely okay to tell that I don't have particularly knowledge about this condition in my mind at the moment. Tell what you know about the generalized management which you feel, and then just say, I am going to say this renal scenario, a renal transplant one, which was appear in the exam, there was written Alport syndrome as well. So you know from the renal point of view what you need to do. So you don't particularly know about the Alport, but don't try to ignore that either. Just simply say, the first thing is, first you will ask her, tell me more about, she's going to tell you about Alport syndrome. Okay, so you can then ask about, okay, about your hearing and about your vision or whatever. And if not, still that pick up this say, so I'm just going to get more information about this, that this particular condition, in addition to what I have discussed with you, if there is anything else I need to discuss, or we need to discuss with you, and it can affect, I will discuss with my consultant, get more information about that, and then I will come back to you. Say that, and then you are saved and you're passed in that station. All right, right then. So bye for today. And then yes, continue your discussion in the group, please. Bye now.
Bye, ma'am. Thank you.
Thank you, Dr. Safia. Thank you.
Thank you, ma'am.